Good morning, ladies and gentlemen. I hope you all had a good gala dinner last night and a good drinking session after the gala dinner and had a good sleep after that. So a really good morning to all of you, bright and early. We are kicking off this morning's Asian Pacific Topic Conference with a very, very important topic, and that is entitled Efficacy and Cost Effectiveness of Gastric Cancer Prevention Through Mass Eradication of H. pylori. Whatever said and done, gastric cancer is still a major cancer in our part of the world. So this topic is indeed very relevant and pertinent for us to discuss this morning. I have the great pleasure and honor to co-chair with my good friend, Professor Kentaro Sugano from GC, Japan. Ken Sugano himself has done a lot of work, bench work, as well as clinical work on gastric cancer. So without further ado, let me introduce the first lecture, which will be given by Professor Kentaro Sugano, and he's talking about the effect of nationwide H. pylori eradication in Japan. Ken, please.
Good morning, everybody, and thank you for coming to this early morning session. Today, I'm going to talk about the effect of nationwide eradication of Helicobacter pylori in Japan. The initial title given to me from the organizer was the efficacy of nationwide eradication therapy to reduce gastric cancer. But the efficacy has a special terms defined in medical economics, which requires ideal conditions. So I changed my title of topic of my talk. And in Japan, eradication therapy of H. pylori was actually delayed. Is there any pointers? No pointers at all, but it's okay. Oh, here. So only in year of 2000, the government approved and the guideline actually issued at the same time that the eradication therapy for H. pylori positive gastric ulcer or duodenal ulcer should be covered by insurance. So, but before that period, some groups specializing in gastroenterology already started to do eradication therapy. One of the typical examples relevant to this topic was published in Helicobacter 2008, but it was published long before this publication in a Japanese journal. As you can see, because of the slide size, they're different from my slide scale. You may not be able to show part of this data, but it's okay. He actually started to do eradication therapy for one company because company are generous enough to cover all the medical costs by their own money. So they actually can start eradication therapy in 1995 before government approved eradication therapy for Helicobacter pylori positive peptic ulcer diseases. And as you can see, the number of patients of active peptic ulcer decreases immediately after starting eradication therapy, and most of them remain in the peptic ulcer scars. And what happened to the medical cost? The initial year when they started eradication therapy cost a little bit more, But soon after that, 1995, the cost for peptic ulcer disease, especially in terms of medication, etc., sharply dropped. And then only at this year of 2000, government actually approved insurance coverage for HP positive gastric ulcer. But in whole Japan, many places actually started eradication therapy for peptic ulcer diseases long before government approval. So this is the claim database which we published some years ago. And then you can see right after insurance coverage, all over Japan, they started to eradicate H. pylori positive peptic ulcer diseases. This is shown red is duodenal ulcer, and gastric ulcer was shown in the blue bars. But the effect of insurance coverage is enormous. It was soon reached almost above 500,000 persons per year. And it stays. And the year of 2010, they also approved for H. pylori positive martoma, ITP, and gastric cancer patients after ESD treatment. But the number is so small, so it can be negligible in terms of the economic consideration. Then, just as you see in the small-scale eradication therapy results in some small company, what happened in Japan was almost recapturate what happened to the company scale. As you can see, the number of peptic ulcer patients sharply decreased, almost 1/6 by the year of 2017. And then the same thing happened to the cost reduction for medication and etc. for peptic ulcer diseases in Japan. And the cost reduction is enormous. As you can see, this is a billion yen scale. That means $6 billion almost spent for peptic ulcer disease treatment, now reduced to a little bit less than 2 billion yen, not $2 billion. So the enormous cost reduction effect this policy had in the past decades. And the simple calculation actually shown here is the total medical cost saved for peptic ulcer diseases is enormous. And this is the cost used for eradication therapy, and this was the cost saved from this eradication therapy from the real world data. And it's only 6% for the saved money was used for eradication therapy. That means this policy is very, very cost effective. And on top of the cost saving for peptic ulcer diseases, this has another benefit to reduce gastric cancer. Actually, this is also shown as a retrospective analysis over 1,000 peptic ulcer patients. Clearly shows that if you eradicate H. pylori in patients with peptic ulcer diseases, you can reduce the occurrence of gastric cancer in this group of patients, almost to the level of 30%, or 70% of reduction of the risk. And that also very cost saving. Additional cost saving is just like this. This doesn't count for the mortality at all. This is a very simple calculation. And if you assume the cost for ESD, about 300,000 yen, and cost of surgery is 1,000,000.5 yen. But this doesn't include other benefit, such as indirect cost, commuting and consulting, and inpatients care, etc. But nevertheless, additional cost saving is like this. So on top of the cost saving for peptic ulcer diseases, additional benefit will be given by eradication therapy for peptic ulcer disease patients. So we think that we should ask our government to approve insurance coverage for gastric H. pylori gastritis. Otherwise, the continuous move from gastritis to peptic ulcer diseases and gastric cancer can occur continuously, because this has a huge reservoir underneath of the surface of the ocean, just like iceberg. So, and finally, our government listened to us, and approval of the insurance coverage for eradication of H. pylori infection took place in the year of 2013. And that, right after that, as you can see, majority of the eradication therapy were for H. pylori gastritis. And the number of patients who were eradicated was gone up, almost more than doubled, over 1.4 million these days. Then you will ask, the effect of eradication therapy on the prevalence of H. pylori infection. Before calculating the effect, we have to consider sort of cohort effect. Every year, Japan is an aging country. We are actually witnessing more than 100, especially this year, from this year, of elderly people are dying. That means this cohort is disappearing from total population. And this cohort has a feature of very high prevalence of H. pylori infection. That means natural eradication is taking place. Whole population are disappearing, and a new generation who is not infected with this H. pylori displacing this population. And that means the prevalence of H. pylori infection in Japan is steadily decreasing. And then we'll add up the eradication effect on top of this. And after insurance approval, this difference expanding almost every year, that will predict H. pylori prevalence in Japan will sharply decrease in the future. As you can see, our prediction shows expected prevalence of H. pylori will reach about 20% in 2020. Then what will happen to this reduced prevalence of H. pylori infection on the incidence or mortality of gastric cancer in Japan? And that policy adopted by the government is a combination of a secondary and primary prevention. And this is not the mass eradication program. It's opportunistic testing and treatment policy and packages of primary and secondary prevention. And then we did our meta-analysis to see what kind of effect this eradication therapy would take place for benign diseases. Most of the meta-analysis, HLE actually did a good analysis, but we can't use that data because Japanese data are scattered around. So we can't use that to estimate our reduction of gastric cancer. And then we did our own analysis. And as you can see, if you eradicate H. pylori in patient group with benign diseases such as gastritis or peptic ulcer diseases, you will expect greater effect on reducing gastric cancer. Odds ratio is 0.32. And then real-world data shows the gastric cancer incidence didn't change much until 2012, which was done by the joint point analysis. As you can see, the turning point is 2012. But remember, this incidence data actually adopted from sample data, not the whole Japanese data. And then you can see number of gastric cancer deaths also started to decrease from 2012 around that part. And now the reduction is greater in every year, and compared to the 2010, we could reduce the gastric cancer deaths by more than 6,000. That means we could save lives for people by 6,000 scales. That's a great policy, I think. And then we did the same analysis and the turning point. This is a crude mortality rate. And then 2011 was a turning point. And that predict the gastric cancer deaths continue to be decreased. But different from the peptic ulcer disease trend, there is a delayed occurrence of a decrease, which has to be explained. One of the explanations is that when I showed you the elderly population are disappearing, but in total, the elderly population in Japan are increasing every year, as you can see, almost straightforward. And those populations have a high prevalence of H. pylori infection, as I mentioned, and also has a very high incidence of gastric cancer. That canceled the effect of eradication therapy. And this is a simple calculation. So every year, additional burden of gastric cancer patients occurs. And then this eradication effect requires time to catch up this increase. And then we'll just calculate the lifetime risk was published in this homepage. And drug cost per gastric cancer death only requires almost 100,000 yen. It's not query. It's total, life cost saving. So you will pay $100,000 or 100,000 yen. That means $100,000 for saving your life. That's easily done. Usually query for the United States, for example, is $500,000 per year. You will pay $500 per year for saving or extending your life. But this cost is negligible comparing with the average query. And so summary, skip all of these, but the bottom line is the large-scale nation-level eradication therapy should be implemented as a preventive policy for gastric cancer, especially in high-risk countries. And Taiwan already did and accumulated data on a similar scale in Matsu Island. So I think it's time for the government to adopt the similar strategies to save their, people in Taiwan. Thank you very much.
Thank you very much, Ken. Right, do you want to take any questions now, or maybe we take questions right from here, huh? Or we can take questions at the end of the whole symposium, and we will listen to the presentations of the others. It is my pleasure now, a second speaker, very eminent person, professor in Yonsei University, Seoul, Korea, in the person of Professor Lee Yong-chan. Yong-chan has spent his whole life dedicated to studying Helicobacter pylori as well as carrying out upper gastrointestinal endoscopy work. So it is most appropriate to have him talk to us about screening and eradication of H. pylori programs in Korea. Yong-chan.
Thank you for the kind introduction, Mr. Chairman. Dear colleagues, ladies and gentlemen, I'd like to thank the organizing committee giving me an opportunity to talk about screening and eradication of Helicobacter pylori in Korea. Actually, I changed the topics of my presentation a little bit so that I omit the H. pylori eradication program, the world's program, because not like Japan, we do not have a nationwide programs to eradicate Helicobacter pylori. I will tell you later what is the reason for that different strategy performed to prevent gastric cancer in Korea. These are the contents of my talk. Start with the statistics of gastric cancer in Korea and gastric cancer prevention strategies and H. pylori eradication in Korea, and my conclusions. Helicobacter pylori's gastric cancer in Korea is still the most common cancer. As you can see on this nationwide statistics, Korea ranks the first, stomach ranks the first as the followed by colon and thyroid and lung cancer. If you look at the male incidence, the stomach cancer is the most common cancer, while in the female, stomach cancer ranks the fourth. The breast is the most common, followed by thyroid and colon cancers. Not to mention that in Korea, there is a steady decline in the incidence of gastric cancer. This black line is the incidence of gastric cancer over the 20 years. In a recent 5 years, there has been a steady decline, annual change of 5%, meaning that in the last decade, we are witnessing a significant decrease in the gastric cancer incidence. Not to mention that if we look at the 5-year survival rate of gastric cancer in Korea, in over 20 years, if you compare with the initial, from 1990 to 95, compared with the recent 5 years, the overall 5-year survival rate almost reaches 80%, meaning that now in Korea, gastric cancer diagnosis is no longer such a threat to our general populations. Speaking of gastric cancer prevention in Korea, there are two strategies. One is the primary prevention, as Professor Sugano nicely mentioned, of H. pylori mass eradication. The secondary prevention will be the detecting of gastric cancer in its early stages, and which is the current Korean strategy. In Korea, we have a very unique nationwide screening program called National Cancer Screening Program. Starting in year 1999, established in year 2004, that this NSCP covers all 5 common cancers, namely stomach, colon, liver, breast, and cervix. And these subjects will receive the required examination free of charge. And this system, this program has been adopted nationwide in full reimbursement starting in year 2007. So for the stomach cancer screening in Korea, after the age of 40 years, every subject is entitled to receive either EGD or upper GI test in every 2 years free of charge. And recent statistics showed that almost compliance rate of this cancer screening program in Korea reaches 85%. So what about this effect of endoscopic screening on stage of gastric cancer? If you look at the 19,000 health examinees data, we could see that those who have received the endoscopic examination showed a significant downstaging of gastric cancer. I apologize for this very busy slide, but this is the data of 16 million Korean cohort aged more than 40 years. And it showed that overall odds ratio for dying from gastric cancer among ever screened subjects was 0.79 compared to the never screened. And those who have received more than 2 times of prior endoscopic examination show better survival. Nevertheless, the limitations of this NCSP for stomach cancer screening are screening tool. The effect of screening tool is not validated, and the cost effectiveness is unknown, and there is a lack of risk stratification, and screening interval and duration are not defined yet. Now let me talk about this Helicobacter eradication for the prevention of gastric cancer, which are role of mass H. pylori eradication and risk stratified H. pylori eradication. Helicobacter pylori prevalence in Korea is steadily declining, so the recent data showed about 55% of general populations are infected by Helicobacter pylori in Korea. Many of the randomized controlled trials in the past has shown that Helicobacter pylori eradication in a normal subject will show a significant decrease in the gastric cancer prevention of gastric cancer incidence. In Korea, also we did a large scale each studies. However, we do not really have a nationwide studies which is showing the benefits of mass H. pylori eradication for the prevention of gastric cancer. For example, this study was done to evaluate whether eradication could affect the incidence of gastric cancer in healthy asymptomatic Korean population. Among the 38,000 health examinees, when we compare the gastric cancer incidence of eradicated to non-eradicated person, it showed clearly that those who have been eradicated show a lower incidence of gastric cancer compared to the non-eradicated group. We all know this nice study which showed even this Helicobacter pylori eradication treatment can show benefits in an old age population, so that even after 10 years of follow-up in the age of 60 years or older, still there's a significant reduction in gastric cancer incidence after Helicobacter eradication. In Korea still, we are following the risk stratified approach for HP eradication, Because of this nationwide cancer screening program is already has been adopted, and it shows the benefits both in survival as well as the downstagings. According to the Maastricht Consensus Report, Helicobacter pylori eradication should be done to prevent gastric cancer. Patient with previous gastric neoplasia treated by endoscopy resection was operations. And current Korean guideline already same as the before that adopted this risk stratified strategy that this Helicobacter eradication should be done for after the endoscopy resection of gastric cancer, and subset of a population with the atrophic gastritis and intestinal metaplasia, and the first degree relatives of family history of gastric cancer. Many of the randomized and non-randomized trials show the benefits of risk reduction of gastric cancer incidence after endoscopy resection of Helicobacter eradication. And this study published in Japan showed that when you receive the H. pylori eradication after the endoscopy resection of gastric cancer, it showed a significant risk reduction of 1/3. Last year in Korea, we have reported gastric cancer prevention with the Helicobacter eradication after those who received the endoscopy resection, and which was published in New England Journal of Medicine. And this study showed that during a median follow-up of 6 years, the metachronous gastric cancer incidence was decreased to half, meaning that hazard ratio was 0.5. Not to mention that in this study, degree of intestinal metaplasia as well as the atrophic gastritis was also significantly improved after the H. pylori eradication. Nevertheless, in Korea still there are some discrepancy of the result of these benefits of H. pylori eradication for prevention of metachronous gastric recurrence after endoscopy resection of gastric cancer. Many of the meta-analysis, like this analysis reported by H.R. Lee, the next speaker, show that H. pylori treatment can reduce the risk of metachronous gastric cancer after endoscopic resection. We all know the Korea hypothesis that gastric cancer predispose dysplasia and intestinal metaplasia. So the issue of atrophic gastritis and intestinal metaplasia is a big debate still in Korea. A large study, a little bit old, performed in Fujian province with the high gastric cancer incidence showed a negative result after the H. pylori eradication to evaluate the effect of prevention of gastric cancer development. But in a subset analysis, those subjects without atrophy or without intestinal metaplasia or dysplasia, the H. pylori eradication significantly showed the benefits of gastric cancer preventions. And recent data showed that in those who pay subset of subjects who had intestinal metaplasia or dysplasia does not show a benefit with the H. pylori eradication for the purpose of prevention of gastric cancer. We know that this meta-analysis that enteral intestinal metaplasia improves while corpus intestinal metaplasia does not improve after H. pylori eradication. In Korea, we did similar studies among 533 subjects. In Korea, the data was that atrophic gastritis in corpus and antrum both improved after H. pylori eradication with a follow-up of 5 years. And intestinal metaplasia also were improved in both antrum and corpus. However, we must be cautious about H. pylori eradication for the prevention of gastric cancer in those who receive the endoscopy resection for gastric cancer. Because the paper also showed that even after the eradication, there is still a chance to develop metachronous gastric cancer, which are 15% over 5 years, meaning every year 3% of the population may develop metachronous gastric cancer. And the risk factors were male gender, severe mucosal atrophy, along with the multiple gastric cancer. So these three factors, metachronous recurrence after endoscopy resection, first-degree family members, atrophic gastritis, and intestinal metaplasia, are the risk factors to be considered. However, until now, no risk stratification-based surveillance program has been adopted in Korea. In summary, ladies and gentlemen, gastric cancer is still the major cause of cancer-related deaths in Korea. The Korean NCSB provides mass screening in 2-year interval, and it provided effective means for secondary prevention of gastric cancer in Korea. HPV eradication is effective in the prevention of gastric cancer in healthy population, as well as the prevention of metachronous recurrence after surgery or endoscopy resection. However, risk-stratified Helicobacter treatment approach may be fit for the best cost-effective gastric cancer prevention strategy in Korea. Thank you for your kind attention.
Yong Chan, you stay at the podium. Perhaps we can ask 1 or 2 questions before you leave. Ken, do you have any questions? Yong Chan, I want to ask, in Korea, this is a national screening program. At what age do you start screening, endoscopy screening?
So after the age of 40 years, you receive the endoscopy examination, either EGD or upper GI fluoroscopy examinations.
Either
fluoroscopy, barium study, or EGD.
Okay, right. You don't use serum pepsinogen to screen?
So pepsinogen studies has not been really adopted as a nationwide screening protocol yet, not like in Japan. Actually the validation of each pepsinogen studies kit have not been really validated in Korea.
And what is your take-up? You offer this to everyone in Korea above the age 40. What is the compliance? How many people take up the screening tests?
So as I told you that this nationwide screening program has been now adopted more than 20 years, and more than 85% of the whole populations are receiving these examinations at the present.
Okay, thank you. There's a question from Peter. Peter, please.
No. Okay. Dr. Lee, thank you for this fantastic presentation and all your efforts in Korea. I have 2 questions. One is in this study by Mori, where you have 3% per year, 15% after 5 years. All these patients have been undergoing endoscopic removal of gastric cancer, or were they operated? And is there an advantage in early gastric cancer if you operate, since the staging, the precise staging, is not possible in all those in whom you remove endoscopically? And that's the one question. Yeah, maybe you can answer this.
No, go ahead.
No, please.
So this is an excellent question, and if you compare between surgery and endoscopy resection for the metachronous recurrence, we have to bear in mind that those who received surgery, either subtotal or total gastrectomy, have a less chance of metachronous recurrence. So that the percentage is far beyond the after the endoscopy resection. But what I would like to emphasize is that even after the HPV eradication and successful endoscopy resection, those subjects are still prone to develop metachronous cancer, higher percentage compared to higher rate risk compared to the general populations. And we must pay attention to those subjects.
And the second, very quick, since you perform for screening upper GI endoscopy, what is the proportion of esophageal pathologies in the context of your initiative?
You mean esophageal cancer?
Yeah,
or
since you can screen the upper GI.
Oh, yes. So Barrett's esophagus is very rare in Korea. I mean, histologically proven Barrett's esophagus is less than 1%.
And squamous?
Yes.
How often do you pick up squamous?
Even with the endoscopic diagnosis, without histological confirmation, I think it's about 3%.
Okay.
But most of them are short segment Barrett's, but do not have a long segment Barrett's.
Thank you.
Okay, Joseph. Please, for Professor Sung, the mic.
Very interesting data from Korea. May I ask, your decline in gastric cancer incidence in Korea, do you think this is more related to endoscopic screening or is more related to H. pylori eradication?
Very excellent question. And to be honest with you, there are three factors to be considered. Although we do not have a nationwide eradication program, many of our general practitioners are very willing to treat Helicobacter pylori infection because of the widespread campaign. And the beginning last year, theoretically, every person Helicobacter positive patient can receive the HP eradication with the minimal prices, not full reimbursement, but very minimal prices. So that's one factor. And the other factor is this nationwide screening program, beginning age of 40 years old. I think the most important thing is the downstaging, so that we have a very remarkable survival benefit over the 20 years. But overall incidence is steadily declining, and that's maybe because of this other factor, age cohort effect. So because those subjects who are old age now will pass away and their proportions will be decreased. So those three factors are the combining factors for this effect, I believe. But we do not have a really good data or studies to show this.
In fact, if I may ask Professor Sugano a similar question. Earlier on, you talked about gastric cancer incidence decline in Japan starting from 2012. That is the turning point, right? So do you think that is related to treatment of H. pylori since the insurance coverage start, or even earlier? Or do you think it is a general decline in H. pylori infection prevalence in your country?
Yeah, thank you. I'm sorry that I didn't have much time to ask the questions, but the data I showed you showing the gastric cancer incidence started to decline from the 2012. It's a sampling in 3 prefectures in Japan, not whole coverage. So there is some difference between the prefectures levels. But nevertheless, it started to show decline from 2012. That means the eradication effect is now taking over the increased burden of gastric cancer cases occurring in from the increased number of elderly population. That requires some time. But if you take age-adjusted population level of analysis, I didn't show it today, it shows straightforward declining. So that means the pressure of the increased elderly population is actually canceling the eradication effect to reduce gastric cancer until a certain point. But the accumulated effect, once you are eradicated, you do not develop gastric cancer. So the accumulated effect of eradication therapy will take some time to take over the increased burden to cancel those increase. That is my explanation.
May I add one comment about the previous songs asked. In Korea, we have a very strong nationwide health program. So we have a good nationwide statistics. Last year in Korea, those who with the dysplasia, they received 20,000 in Korea. Meaning that if we treated the 20,000 gastric adenoma regions, and if the subfraction of those dysplasia develop into gastric cancer, if we treat it with endoscopically, then gastric cancer will be declined. Those are the other factors.
I just wanted to add just on what Ken had said and what Joseph had asked. In Japan, before you treated Helicobacter pylori, you were already screening endoscopically for gastric cancer. So to answer Joseph's question, you see, if you look at the decline when you were just scoping and screening versus after 2012 when you were treating, you could see how the curves were like. That could tell us which has played a more important role in eradication and bringing the prevalence of H. pylori down, isn't it? Yeah. Right. What were your observations on that? But that means after 2012, with H. pylori therapy, that there was even greater. Yes. So with endoscopy screening, there is already a decline, but with endoscopy and H. pylori,
the endoscopy screening was not adopted as a national policy, totally different from the Korea. Korea also adopted double contrast X-ray screening for gastric cancer, but the majority of the people prefer to be screened by endoscopy. Over 90%, I understand.
Yes,
right.
90% prefer the endoscopy.
So 90% are done by double contrast X-ray in Japan. So the majority of the early cancer are discovered not by screening in Japan, but the regular daily clinical practice discovered early cancer. Yeah. So the role of screening for gastric cancer in Japan is very small, so it's not cost-effective policy.
Okay. Right. I think David, some comments, please.
Well, one of the problems that we all have when we're dealing with these data is that we're seeing overlapping events. Now, if we look at America as an example, we saw the first thing that happened was that, again, it was the number one cancer. The average person developed atrophic gastritis. And then we changed the diet and we changed sanitation. Helicobacter pylori started to disappear, but more importantly, just like in Japan, atrophy started to disappear. So if you took a 40-year-old American or a 40-year-old Japanese today, most have no atrophy or limited. So the precursor lesion began to disappear and the disease disappeared. And in America, we gastroenterologists took credit for the disappearance of cancer, although we had nothing to do with it. It was a change in diet, et cetera. And in fact, if you look at the Japanese data, you would see where they're doing exactly what America did, and gastric cancer was going to disappear, and is going to disappear if they do nothing, if they did nothing. And it would disappear about the same time. That fall is related to the natural history of gastritis in Japan. We can improve that, and we can shorten the whole time, and we can help some patients. But most of the advantages that we're seeing in these populations were going to happen whether we did anything or not. But there are other populations that haven't moved that far down the line, and we can make a really big difference. So when one looks at outcome, one has to look at what will happen if we do nothing. And if we look at Japan, we find that the colon cancer incidence is now higher than the gastric cancer incidence. And it's going up, and gastric cancer is going down. And so the question the government's going to have is, when do they switch and start putting the scope in a different orifice for public health purposes? And there are no answers that I know of to any of these kinds of questions. The other problem we have is the Korea hypothesis, because we learned that there was this step of things. And that's not what Korea actually said or did. It was kind of changed after Helicobacter came along. So this is a histologic change, but it's all reversible. So you can go from atrophy to no atrophy, and we see that. You saw that in your study. Things disappear. But there's another event going along simultaneously, and that's in the stem cell, where you're having increasing damage and increasing genetic instability. That's independent, and we don't know how to reverse that. So that's just what you saw so beautifully, that the histology gets better, but the risk stays high. We've taken away the inflammation, so we've stopped increasing the risk, but we have that baseline risk. And we don't know how to measure that, we don't know how to change that. And so therefore the key is to prevent that from happening and not to worry about, because intestinal metaplasia does not become cancer. Stomach becomes intestinal metaplasia that can go backwards. And you can take a patient, for example, with, as you know, with atrophic gastritis, the best kind would be autoimmune, and you can completely reverse it, make all of it go away and all the gastric cells come back. So that's a reversible process. So when we say to ourselves, IM is bad, no, IM is a marker that there's been a lot of change to the stem cells, and that's what we need to worry about. So there's so many events going on, and our minds and our ability to measure is one at a time. And I don't know how to do it.
Thank you, David. Thank you. We will take more discussions later on, but we need to invite our third speaker, and he is Professor Lee Yi-chia from Taiwan. And you know, the Taiwanese have been doing excellent work with respect to screening and eradication of gastric cancer. So we invite Yi-chia to come and give us his lecture first.
Thank you very much for your introduction. And And in Taiwan, because the gastric cancer actually is not the most important cancer, so our government only approved some population who had a higher risk or intermediate risk for gastric cancer. So I will present you about 3 populations. The first population appeared to be a pioneer. It is a high-risk population living in offshore island starting from 2004. The other population is intermediate risk population. That is Zhanghua County. That's at the central of the Taiwan. Now finally, the last one is because in the whole population, there must be some high-risk population living in the whole island. So the most currently, our government encourages us to perform the mass screening eradication for the indigenous population starting last year. And this is a Matsu Island. I hope someday you may have an opportunity to visit this island. This is different, with a different culture. It's very similar to the Fujian province in mainland China. And they have a different culture and a lifestyle. They are traditionally very high salt index. Also, their gastric cancer risk is very, very high. And this is Matsu Island actually composed of 5 small islets. And the H. pylori infection rate is more than almost 70%. And it is very isolated and limited in medical resources, and the endoscopy is very, very difficult at that time. And so the Matsu Island experience is lasting for more than 20 years, and we have a lot of experience. The first experience is using the Japanese staff to use the pepsinogen to identify high-risk population. And the second period is the elimination of the risk factor using the H. pylori screen and treatment. After that, we also consider that because some patients still carry the gastric cancer risk after HP eradication, so we want to eliminate the rate of the gastric cancer in this population. The first strategy we use is the pepsinogen used before the eradication treatment. But at that time, the positivity rate is high, almost 20%. Almost everyone needs endoscopic referral to test if he or she have a gastric cancer. But that program is substantially constrained by the population attendance to the program. Also, the referral rate after the positive test is very low. Overall, the gastric cancer detection rate is very low. Even we know that the pepsinogen itself is still valuable to stratify the population risk. As you can see, for gastric cancer, it's about 3 to 2-fold higher risk if you test positive for pepsinogen. By contrast, we use the liver cancer as a comparator. There's no significant change, indicating that pepsinogen is really specific to the stomach problem. So after that, we're trying to implement a mass eradication program. Our hypothesis is that the strategy to decrease the inflammation process can reduce the gastric cancer risk in this high-risk population. And starting from 2004, as you can see, I was very young at that time, and we used the first stage of the urease test and providing the antibiotic treatment. Some patients also received the endoscopy screening with the histology evaluation over the entrance and the body following the standard protocol. And up to now, we have performed the 6th round of a mass eradication program. As you can see, the majority of those who remain positive nowadays are the immigrants from mainland China or the Taiwan main island or the young generation. And actually, the majority of the adults in the Mazu Island now is get rid of the H. pylori infection. This is the prevalence rate and the reinfection rate of the Helicobacter pylori in this island. As you can see, the HP infection rate substantially reduced, almost 10% now, and the reinfection rate declined from 1%. Reinfection rate declined from 1% to 0.3% nowadays. So Helicobacter pylori appear to be a very small number population in this island, but the government need evidence. So we did a systematic review and the meta-analysis to prove that in adult patients, combined with the many data from Korea and Japan, can provide about 50% of the risk reduction. So government are very happy about the results, so they continue to support our program on that island. But we also look at the cancer registry data. This is the pre-eradication data. As Professor Joseph Song has mentioned, that screening can have an early detection effect. But when we look at the long time trend, we use the pre-screening data as to build a prediction model. We found that using this histological control, compared with what you see and what you expect rate, actually the reduction of the gastric cancer in this population is still about 50%. So this is still very promising effect. And the additional benefit is the peptic ulcer. In Mazu Island now, peptic ulcer is, generally speaking, very low. So the people are drink alcohol more frequently nowadays. But I think that is also a very good beneficial to reduce the risk of peptic ulcer, and the medical resources will be saved quite a lot. And the most important thing is that we must the awareness of lifestyle change, especially for the very high salt fruit and some prickle fruit, because they rely on the fishing. So every year they will put the fish into a very high salt pot, and they eat it gradually. I think we have changed a lot and published a lot of newspaper on this newspaper called Mazu Daily News to aware the lifestyle and emphasize the importance of the stomach, health stomach. And nowadays, the Mazu Island is famous for the delicious fresh and the seafood and the very strong alcohol. I hope someday you can taste that. And also the beautiful scenery and the very worthwhile visiting. But back to the endoscopy picture, we found that even though the inflammatory process can be substantially reduced by the H. pylori eradication, there are some change on the genetic level or epigenetic level that become irreversible. So some cases still develop gastric cancer following H. pylori eradication. especially for cases with atrophic gastritis. And even though H. pylori eradication can regenerate the mucosa, increase the gastric acid output, but the risk remains in some of them. Therefore, under the support of the Matsu government, we did again using the mass screening after eradication. We used the gastric panel, not many composed of the pepsinogen, to stratify the population again. And as you mentioned that we have performed the pepsinogen before the eradication. Now we perform the pepsinogen once again after the eradication. As you can see that those with a high-risk group actually are very low, only about 3%. We test the hypothesis that does the pepsinogen method remain effective following HP eradication. However, our research assistant and the local people have informed me that a lot of people who have a gastric cancer diagnosis were tested negative. And the program seems not very successful because in this large number of population who are considered health, they have a health stomach, actually they still carry the risk for the gastric cancer. So this is the RC curve to show that the predictability of the pepsinogen method and to predict the extensive pre-migratory gene of gastric cancer. As you can see, the AUC under the RC curve is only about 70%. Therefore, we search for help from our Japanese collaborator to measure the irreversible damage of the gastric mucosa, that's called the methylation level. We found out that this kind of damage can be quantified and is much better than the pepsinogen method to stratify the population risk. Let me back to this picture. For example, in this subject who consider at a low risk, they may have an opportunity to receive endoscopy and we can measure the methylation level. And those who have a lower level can exclude from the surveillance. And actually that will substantially reduce the number of endoscopy. So that is what we learned from the Matsu Island population. I think that that population actually acts as a pioneer in the whole Taiwanese population. And so we can gradually move to the population approach as a mass eradication to the individual tailored approach about the endoscopy screening for certain patients who carry the remain to have the high risk for gastric cancer. Now I will move to another population, that is the Zhanghua population. This is has an intermediate risk of the gastric cancer. And the H. pylori infection rate is about 35%. And, you may see that there's a high-risk population. I will tell the story of this high-risk population later. In Taiwan, actually, colorectal cancer has a higher burden than gastric cancer. As you can see, there's a 4-fold incidence rate and 2.4 mortality rate compared with that of the gastric colorectal cancer. So our hypothesis is that in Taiwan, we have a nationwide fecal immunochemical test for the colorectal cancer screening. So we want to test the hypothesis that if a FIT test combined with the stool antigen is applicable in a large population, and what is the impact, the short impact on the CRC screening, and what is the long-term impact of the gastric cancer incidence and the mortality. And this is our real screening. This is a community-based outreach screening. The stool test is here, and the feces is not real, but it's look like the real. And we educate people to take a stool sample in the screening session, and they will return it and we will report it then with the H. pylori data and the fecal immunochemical test. And we invite the whole population living in the Zhanghua County and all the medical, hospital, clinical, and the public health center, and do a randomized control trial. And we randomize the whole population eligible for FIT, that is aged 50 to 69, and we separate the list to the CAS invitation list. as well as a control invitation list. And currently we have a complete result, and I found that we first noted that in addition to the fit, addition provide of the HP2 antigen that has a substantially increased attendance rate of the screening, mass screening. Actually, our fit-based screening program has been constrained by the lower participant rate. And the other interesting finding is that those who have two combined stool tests have a higher colorectal cancer detection rate. And we consider that because people choose to receive the additional stool antigen test actually may have some GI problem. They have this kind of GI problem have shared a similar risk factor. For example, male, gender, or first screening, or they smoke. So they receive the two tests, and the colorectal cancer detection is much higher in this group. We believe that that will be a very substantial benefit if the subject can receive the two tests instead of the FIT alone. Now, finally, I will move to the high-risk indigenous population and who live in the eastern part of Taiwan. This is a very beautiful area, and the indigenous people, actually, our best athlete in Taiwan are indigenous people. They are very strong physically, but unfortunately, their life expectancy is much lower. And as you can see, overall is lower than 8 years compared with those is the non-indigenous people. When we look at the cancer registry in Taiwan, we found that the gastric cancer, the incidence and the mortality rate seem to be very high. So this is a start point. We can intervene the gastric cancer disparity in the gastric cancer burden as a leading point to simultaneously decrease the risk of, for example, the esophageal cancer and the oral cancer, because that they have exposed to multiple additional risk factors compared with the non-indigenous people. So this scale is quite large, cover about 55 indigenous townships in Taiwan. We invited to patients who aged 20 to 60 years because we know that the mean age for the gastric cancer diagnosis in indigenous population is about 65. We moved to the younger age, trying to prevent the occurrence of the gastric cancer. We use a urine breath test instead of the stool antigen test because these are very remote areas. We have tried to use the stool antigen test, but the stool antigen test decay during the process of transportation. For the same area, if we use the stool antigen test, it's about 10% of positivity rate, but if you use the urine breath test, it's about 60% positivity rate. That is very substantial. For those who have a test positive, they will receive the first-line treatment after the evaluation of the necessity of the endoscopy examination. Then we'll provide the second-line and the third-line treatment. And we ask the local hospital and the public health center to support this program. We have a lot of difficulty to reach this hard-to-reach population. First of all, the delivery of the care is difficult because the majority of them are living in the high central mountain of the Taiwan. So we must incorporate the screen survey with the established healthcare system. And so I have to go to the healthcare center in each indigenous population. And also, we cannot treat the Helicobacter pylori by ourselves. So we have to disseminate the H. pylori management information to the first-line doctor, nurses, and the public health worker who work with this population. This is also, this is very important. This is our chief of the HPA in Taiwan, and we also use the awareness, trying to get adequate communication, social mobilization, and education for this population. Actually, we have lack of the knowledge for the improve their stomach. As we will do in tomorrow, we will incorporate the health stomach initiative at Peter have raised this very, very interesting timing to increase their awareness. I think that's very, very important. But we still have problem. Then it is a population, they have a higher risk of the, first of all, the eradication is not good. So we are trying to identify a best regimen for this population. For example, the young age group actually has a very low compliance because they are lack of time. Second, they has a lower health incentive to treat the Helicobacter pylori. The third line is the smoking and the betel nut chewing actually are highly prevalent in this population. So their gastric acidity is increased, so making the Helicobacter pylori eradication therapy less successful. Finally, we also have some preliminary study showing that the antibiotic rate is quite high. So this is a lot of problems. I think this is a very good challenge for everyone in Taiwan to focus on this high-risk population. And this is a slide. We have learned a lot from the northern part of the North Taiwan to the southern part. Is Namasia is a Kaohsiung, is close to this area, but it took about 2 hours by car. Our finding, this is my conclusion. Population-wide screening and the eradication of H. pylori should be integrated into the healthcare priorities in order to allow the limited resources to be most effectively allocated. Thank you very much for your attention.
Thank you, Professor Lee, for your enormous effort to get the good evidence. But I think it's time not to do the clinical trials anymore. It's the time we should implement the eradication therapy as a policy. According to my experience, the guidelines, etc., never worked. Only financial or political, scheme work actually did work. So I think government of Taiwan will listen to you and adopt the similar policy to cover all the Helicobacter pylori eradication as an insurance coverage. Anyway, Joseph.
Professor Lee, very, very interesting talk. I have 2 questions which are related to your statement that with eradication of H. pylori and the histological improvement, serological stratification is not that useful. You have this statement, right? So my question is, number 1, how good is pepsinogen test in detecting corpus or pangastritis in your study? Because we have done similar things many years ago, and the pepsinogen prediction of gastritis is not, atrophy is not that good. The second question is why you have such a statement? Does it mean that after eradication of H. pylori, there is actually a regression of intestinal metaplasia and atrophy in your population, or is it just corpus gastritis you're talking about?
Yes. Actually, we have, based on the module data, because this population has received the eradication therapy before HP eradication. So we have the data after the eradication. We found that the sensitivity declined from 80% to less than 60%. So in that certain status, we can make lost a lot of patients who still carry the gastric cancer risk. So I think after H. pylori eradication, we should consider other markers to enable early detection of the gastric cancer. Yeah, I believe after eradication, because a lot of patients, their gastric mucosa may regenerated and no longer have an atrophic change. That's the reason why pepsinogen cannot identify these people. Yeah. And sorry, what is the second question? Sorry.
The question is actually very simple. How good is pepsinogen test in identifying atrophy?
As our slide showed that before H. pylori eradication is still effective, I believe so, and substantially reduce the risk and accuracy is much better, but after that it's still substantially reduced. So we have a problem in the new secondary prevention program in Marshall Island. Thank you.
Okay, so the quick questions. So maybe the importance, Dr. Lee, Professor Lee. Okay. Usually there are some issues we must be think about is mass eradication is antibiotic resistance, I think. So in the Marshall Island you have already more than 20 years or something. So how about the prevalence of antibiotic resistance in the early years and currently it's also increasing, or it's okay, no problem for think about resistance?
Yes, this is a very interesting study. We have actually not only for the mass eradication, we also did some randomized control trial, and that is conducted by Professor Liu Ziming, and we found that the antibiotic resistance not increased in that population, which indicated that the retest and the retreat seem to be very important because we routinely provide the retest and the retreat for this population. And for those who have a multi-drug resistant cases, we have monitor this patient and ask them to come back to Taiwan to receive the antibiotic resistant susceptibility test. So in that population, antibiotic resistance rate is not so high. But let me emphasize that in the indigenous population, there are a lot of other problems. For example, they have a higher prevalence rate of the tuberculosis. So their antibiotic use is much higher frequently than the non-indigenous population. So that is a problem. We found that the dual resistant strains are very highly prevalent. So we need additional treatment. I think that we will invite you to join this study, trying to figure out what kind of the regimen is the best. Yeah, thank you.
Any more questions? Because we are far behind the schedule, so we move on. Thank you very much.
Finally, I will respond to the Professor Sugano. Our Vice President will come today, so I will try to find a time to persuade him. Thank you.
Now the last part of this session is given by Professor Chen from Taiwan, and he will talk about cost effectiveness of mass eradication. Please.
Thank you for your kind introductions. Dear ladies and gentlemen, the topic is cost effectiveness of mass eradications. Gastric cancer is the sixth most common cancer and the third most common cause of cancer death. In Taiwan, our data shows that gastric cancer leads into a significant economic and expected year of life loss. The life health expenditure per patient was about $70,000, and the expected years of life loss was about 12 years in female and 9 years in males. Helicobacter pylori is definitely the major cause of gastric cancer, and currently H. pylori could be eradicated by antibiotics effectively. And the systemic reviews report that gastric cancer risk could be reduced by H. pylori eradication by 35% to 50%. However, only 1% to 4% of H. pylori infected subjects progress to gastric cancer. Therefore, is the screening and the treatment strategy for H. pylori infection cost effective to prevent gastric cancer. Here are the definition of the cost effectiveness analysis or the cost utility analysis. The cost means that how much money you should put into the strategy, and the effectiveness is how many natural units you can save or you can gain, for example, last year. And the utility is what you gain according to personal preference, for example, quality adjusted last year quality. And this analysis uses the incremental cost effectiveness ratio ISA to determine whether it was cost effectiveness. The ISA is calculated by the cost of screening and treatment minus that of cancer, then divided by last year saved or by quality gains. And the most common threshold value is $50,000. There are two systemic reviews to validate the cost effectiveness by use H. pylori screening and treatment to prevent gastric cancer. This is the first one. In this systemic review, it includes 19 studies to validate the issues. And the method for screening includes serology, stool antigen testing, endoscopy, or X-ray. In this systemic review, all studies show that the screening for H. pylori was cost-effective, usually by serology, either in the Western or in Eastern Asia countries. Among these 19 studies, 12 discuss the various methods for H. pylori screening. This table shows 5 of these 12 studies. And the ISAs in these 12 studies are ranging from 6,000 to 26,000 US dollars, which are all below the threshold 15,000 US dollars. And in the sensitivity analysis, there are 5 variables which determine cost effectiveness. The 5 variables are: first, the incidence of H. pylori; second, the estimated cancer reduction achieved; the third is the age at the screening; and the fourth is the incidence of gastric cancer; and the fifth is the cost of endoscopy and or cancer treatment. For the first issues, and there are papers discussed about the cost effectiveness according to the different instances of H. pylori. This is the second systemic review to validate these issues. In this systemic review, the authors validated the cost per lab year gain by H. pylori screening according to the prevalence of H. pylori. The data shows that in the low prevalence countries, the costs are ranging from 10,000 to 35,000 US dollars. For example, in the United States, in United Kingdom, in Finland, and in Canada. And in the high prevalence countries, the costs are ranging from $200 in Colombia to $17,000 in Singaporean Chinese. The second variable is the estimated cancer reduction achieved. Patsonet conducted studies to validate the correlation of efficacy of H. pylori eradication with the cost effectiveness in different populations. This figure shows that in the total populations, the efficacy, the cost effectiveness could be less than 50,000 if the efficacy is higher than 15. And in the high risk group, such as Japanese American, cost effectiveness is favorable even at the 5% efficacy. This study is conducted by Harris. In this studies, the author also validated the correlation of gastric cancer risk reduction by curing infection with ICERs. This figure shows that in United States, H. pylori screening and treatment would achieve cost utility with a higher than 50% reduction in cancer risk by curing the H. pylori. And in Japan, it has cost utility with a 0.6% reduction in cancer risk. According to the gastric cancer risk reduction rate, 35% to 50% reported by Professor Ford and Lee. The H. pylori screening and treatment strategy could be cost effectiveness in either United States or in Japanese. The third issue is the age at the screening, which depends on the population studies. Studies conducted in Western countries shows that the ICER value increased as the screening starting age drops. This paper shows that screening at the age higher than 15 years old have always lower ICER than starting less than 15 years old. However, there are two studies which conducted in Eastern Asia shows cost effectiveness at the screening starting age since 20 to 30. One is conducted in Taiwan, and the other one is conducted in China. This figure validated the correlation of age at the screening and the cost effectiveness in different populations. This figure shows that in 5 people, the screening appeared to be cost effectiveness after the age of 45 or 50. And in very high-risk groups, such as Japanese American, screening could be cost effectiveness even after age 10. However, in the general populations, screening in the childrenhood does not appear cost effectiveness. This is a study conducted in Mazu Island, Taiwan by Professor Lee. They compare the ICER between the primary prevention and the secondary prevention. The primary prevention is start at 30 years by initial carbon-30 urea breath test, and the receive H. pylori eradication is positive. The second prevention is screening by serum pacinogen test first, and then arrange patients with extensive atrophic gastritis to receive surveillance endoscopy. This paper shows that early H. pylori eradication at 30 years old is more cost effectiveness than the secondary prevention strategy. Professor Lee also validated the correlation of the maximum amount of willingness to pay per life year gain with probability cost effectiveness. Compared with no intervention, annual high-risk screening from 50 years and once only high-risk screening from 50 years. The strategy with once only chemo prevention from 30 years was most favorable to be cost effectiveness. This study was conducted in China, and their data shows that with the screening starting age increasing from 20 to 60, the cost of screening and treatment will also increased from 1,000 more to 30,000. Our study group also conducted studies according to Taiwan National Cancer Registry database. And our data shows that either screening by carbon 30 UVT or serology, the ICERs in young adults aged from 30 to 49 is similar to that in the middle-aged adults from 50 to 59 years, but lower than that in adults older than 70 years. This is another study conducted in Chinese by the Lu Hong's group. Their data shows that the ICER of the screening and the treatment was around $407 per quadrigen, or $60,000 per life year saved. Lu Hong's data also validated the effectiveness, the correlation of effectiveness and the cost in different follow-up periods from 5 years, 10 years, 12 years to lifetime follow-up. Their figure shows that the cumulative effectiveness was similar, with screening age increasing from 20 to 60. However, the cumulative cost was increased from 20 years to 60 years. So this figure shows that the screening and the treatment strategy at a younger screening age was more cost effectiveness than that at an older screening age. This study was conducted in Singaporean Chinese. This study used a different threshold. They used an adapted threshold, $28,000. Their data shows that the age, the screening and the treatment strategy would be cost effectiveness if the age at the screening since 30 or 35 years. This is a study conducted in the occupational health setting in Japan, screening by serology or screening by serology. This paper shows that the cost was increasing with the screening age increased. However, the utility was decreased with the age increased. So this paper shows that the ICER would be smallest if the screening study age at 20. This is a study conducted in New Zealand to compare the difference of cost effectiveness between Mori and non-Mori, because Mori is at higher risk of gastric cancer. This data shows that in Mori populations, the screening program since young was more cost effectiveness. However, in the non-Mori populations, the screening program since age 50 was more cost effectiveness. So the fourth issue is the incidence of gastric cancers. This study was conducted in a specific high-risk group. This high-risk group involved patients with early gastric cancer after complete resection by endoscopy. This study was conducted in Korea by Dr. Shin. And they found that the cost of eradication was similar to the patients without H. pylori eradication. However, they concluded the ICERs for eradication could be less than $4,000 per life year gains. The fifth issue is the cost of endoscopy or cancer treatment. There are 7 studies use X-ray or endoscopy to screening high-risk populations. And this 7 articles concluded screening by X-ray or endoscopy was cost-effectiveness. All of the isotopes were below the adaptive thresholds. However, screening by endoscopy was more cost-effectiveness than by screening than by X-ray. This is the second systemic meta-analysis. And this meta-analysis includes similar studies and concluded all studies found that H. pylori screening for gastric cancer prevention in the general population were cost-effectiveness because the cost were less than the common threshold, $15,000 US. And the strategy was cost-effectiveness either in the high-risk group or in low-risk populations. And the serology test and the stool antigen test were more cost-effectiveness than the carbon-30 urea breath test. And the retreatment screening, repeated treatment or repeated screening was not cost-effectiveness. According to these papers, we could conclude that first, the H. pylori screening and the treatment strategy, usually by serology test, have potential to be cost-effective to prevent gastric cancer, either in the low-risk or in high-risk populations. The screening study age depends on the population in a region with low or high prevalence of H. pylori. In the high-risk regions, screening study age was around 20 or 30 years because the prevalence of the pre-cancer condition increased with age, and this reduced the efficacy of H. pylori eradication. And in the low-risk regions, screening starting age is around 40 to 50 years. Screening in children's food does not appear cost-effective in the low-risk regions. Thank you for your attention.
Thank you very much. Any questions? Because he summarized all the cost-effectiveness studies against the gastric cancer prevention. And the point, most of the studies actually you cited as sort of narrow-minded studies. Actually, they only focus on the reduction of the gastric cancer. But as I talked in my presentation, the eradication of H. pylori can prevent occurrence of peptic ulcer diseases. That is another huge benefit. In addition to that, other benefit is already shown for reducing the cost for functional dyspepsia. So including all these benefits, why not doing the eradication therapy for all the infected people? That's my opinion. How do you think about it?
Sure, and these studies validate the cost effectiveness just only in gastric cancer prevention.
Any questions? If not, please remain on the podium, and I'll call two speakers. We forgot to give you a sort of credit, and a photo session is required. So please come up to the podium, and Professor Go will give you the certificate.
we have to proceed, and I think Professor Wu is the chairman for this session, is not here, but let me take the place of Professor Wu, and it is my greatest pleasure and privilege to introduce Peter Malfaihana. He truly needs no introduction, but he was the founder of the creator of the famous Maastricht Consensus, and throughout these years, he has shown that he is an outstanding clinician, researcher, teacher in Helicobacter pylori infection, as well as allied diseases. So Peter, without further ado, please take the podium.
Thank you, KL. The introduction is the one of a good friend, and I'm very pleased to be here. And there are two things that I need to contemplate before I enter in my presentation. I've been here 20 years ago, and there are two things I remember of Taiwan over the last 20 years. Number one, I survived the earthquake together with many others here, and the wonderful hospitality that I received then and now, and I would like to thank for the beautiful invitation to the meeting. The problem is I need to go on. So another aspect I would like to show, can you please help me to go ahead, because I cannot. Ladies, could you please help me just to, because it doesn't work. There's no light. No, I need to go on with the slides. Not just how to go on, because it doesn't work. No, it doesn't work. This one here, okay, but I cannot see. I cannot, no. I cannot see. Light, you need light, or this here. Don't worry, we will move. It's, you can't see.
Yeah, that's right. That's the problem with all of us nowadays.
Yes, the other slide I was going to show is this one here. Can you maybe just show me so that I keep the button pressed? Since I'm traveling the world, but nobody travels to my home, I want to show you my home, where I usually start thinking of what I'm going to tell when I'm traveling. So this is my village. This is my glass of wine that you can see, which is very important. It's a moderate consumption of good wine. You see on the mountain to the left, there is still snow, so we can ski, walk, hike, drink, and have a good life. And therefore, the condition that I bring with me when I travel is quite okay. Is it working now? Thank you, Jinming. Thank you very much. Try. So the need, no, it's not. No, so maybe this. Let me start with the need. Why do we need a vaccine? High prevalence of infection, high burden of disease, and we can prevent, and of course, we may even make use of a vaccine to add the therapeutic armamentarium. Now, there are two big challenges. One is the resistance to conventional antibiotics, which would demand for a vaccine, and there are health economic aspects, like for the mass eradication, therapies are much more expensive than vaccines used to be. Well, everybody has these figures present, the high number of infected people worldwide, the high incidence of antibiotic resistance, which includes several of the key players in the treatment regimen. So, is it now? All right. And of course, the global incidence of gastric cancer. The 5-year survival, especially in Western countries, is usually less than 30%. And with this in mind, we need to go to develop something that could prevent the gastric cancer. 2 years ago, there was the G20 in Germany. You see all the endorsing academies, and the knowledge existing at the time induced this G20 to say there are infectious conditions like cervical carcinoma, hepatoma, hepatitis C and B, and stomach cancer, and there should be taken preventive actions which are best by vaccination. But we don't have vaccination for hepatitis C, we don't have vaccination for Helicobacter pylori, but we have, of course, options of therapy. There are two ways: mass eradication or vaccine, and mass eradication was proposed for high-risk countries in the Maastricht 5, but of course the selection of antibiotics are crucial, and antibiotic stewardship, of course, is required. Now, yesterday with Professor Graham, we had a discussion about what is the bar, what should you reach in your or with your eradication therapies. And you can see that if you fail, so this is a refractory infection, there are two ways: either genotype resistance guided or just empirical, using therapies of which we know that there are no resistance issues that cannot be overcome. So now that's the one way, and my task is H. pylori vaccine. If we have this opportunity, then of course we can prevent all the potential consequences, and we can replace all the antibiotic-based therapies, so no limitations for the use. There was experimental background, very encouraging, starting in the early 90s. There were many antigen candidates used, many routes of administration. I will not enter in detail, but basically you can provide these vaccines. And I started to work with Behring in the early 90s, and we used rabbits, and we provided whole cell approach, a whole cell H. pylori antigen approach by nasal application, but the rabbits died because they developed pneumonitis, mainly due also to the adjuvants. So it was a failure, and the models, just to summarize a few, did not only show that there was protection against infection, but also the infection itself could be cured by the vaccines used. So one of the key studies, just to take out one of the experimental moments by the group of Adrian Lee, where they used therapeutic immunization against Helicobacter pylori infection. But you can see that the model was an H. felis, not an H. pylori. And this cannot be translated into the clinical and human situation. So there are many limitations, which include that experiments do not exactly replace what happens in humans. Felis is a natural infectious agent in mice, but lacks important pathogenetic factors, and H. pylori requires significant adaptation. So there have been, many of you remember the study by the group of Rappuoli, published in Science then, where they showed how the H. pylori needed to passage many times in order to adapt to the human stomach. And then, of course, the complexity in innate and adaptive immune response was not sufficient. Now, this is my part that I would like to maybe show you that it's not all lost in our research towards H. pylori vaccine development. What has been used in humans? Inactivated whole cells, soluble recombinant urease, salmonella vector urease, and different recombinant antigens with a variety of adjuvants, often of E. coli labeled toxins, but even some cholera toxins have been used. Again, very few examples. formalin inactivated whole cell, where they used 41 H. pylori negative and positive subjects, they found there was a marginal increase of the antibodies and the interferon gamma in the non-infected. Again, side effect, or let me stress side effect in all these studies was diarrhea. So the whole cell vaccine died. Immune response was found. There were sharing of homologies, even for the LPS and potential cross-reactivity, but again, what I briefly just mentioned is the induction of autoimmune diseases. So no further pursuits. One of the important studies came from the group in Switzerland of Michetti and Andre Blum. They tested 26 H. pylori positive subjects, provided them the urease orally at different doses, once per week for 4 weeks with the label toxin. Was published in Gastroenterology, and again, as you see here, diarrhea happened in 66%, so it was not well, or let's say it was unacceptably badly tolerated, and this was not pursued any further. Here you see what they found in their H. pylori positives. There was some reduction in colony forming units, but that was all. There was no clearance, there was no eradication in this. Then there was the use of the Salmonella vector urease. They used the Salmonella typhimurium. Few patients, volunteers, they developed antibodies, but they were not cured. The lessons, oral and rectal route works modestly, and the oral administration of recombinant urease requires addition of safe but strong mucosal adjuvants, which basically doesn't work because either it's strong and then you have these unsafety issues, or it is not strong enough. So 12 years ago, a summary of the mostly urease-based vaccine, which can be concluded with one sentence: it did not lead us any further in spite of interesting insights in the immune responses. Now, step ahead. What could be used as a model for proving the concept that vaccine works? A challenge model or a field trial? There were two famous persons that challenged themselves, Barry Marshall and A. Morris. Very interesting to view their infection and the outcome of the infection, what happened on, but the study by Morris, where he performed repeated endoscopy, was a little more helpful. On the other side, it was the proof of Koch's postulate for gastritis, for the infection, and this is when we visited Barry. But the real step was made by David Graham. David, pleased to see you here, with your challenge model, where you took not very, let's say, sympathetic American guys. As I understood, they were in jail, right? So you went there, took them from jail, and said, either you survive or not, we challenge you with Helicobacter. You used a CAC-negative strain, sensitive to all antibiotics. 90% became infected. They developed all symptoms with acute and chronic gastric inflammation with an increase in EL8. Was basically, this was the starting of the first vaccine trial, which then was conducted in Berlin in the group of Ebischer and Thomas Meyer, and they performed a vaccination with a typhimurium-based Salmonella vaccine, where they delivered the antigens through swallowing this into the gastric mucosa. The issue was, again, just look at this data, 5 of 58 became negative of those challenged with a CAC negative strain. Move on. In the group of Rappuoli in Siena, with different companies that acquired this company later on, there was the approach with a vaccine based on 3 recombinant antigens, well known to you because they play an important role in pathogenesis of the infection. And we first tested the safety and immunogenicity in a group of H. pylori negative volunteers. And you can see here, depending on the different boost technologies, 3 boosts of this vaccine. There was a development with the low and also with the high dose of antibodies and also of T-cell proliferation. So the antibody, humoral, and the cellular immune response was promising. Therefore, next step, we performed in Magdeburg a randomized phase 1/2 observer-blind placebo-controlled trial and recruited for screening purpose 160 subjects. We finally found 63 negative, vaccinated all of them, 3 different points of vaccination, and 34 subjects were then finally challenged. We started with 7 on the first day to see about the safety, and 29 of these 63 remained with no challenge. I'm showing you this because we still have a lot of material of this patient and start even now to study what may be the immunological specificity in this condition. So 34 patients, placebo and vaccine in random order. These were my 7 first students that accepted not only to undergo the vaccination, but to be challenged. And finally, these 16 of these remained positive at the end of this CAC positive strain provided by David Graham at the time, and 18 became negative. But the problem was that in the placebo group, almost half of them became negative and only a few more in the vaccine group, which shows that in the adult, mature immune system, the infection gets cleared spontaneously in many of them. So one issue is the model is not a natural model because infection occurs in childhood and the adult model may not fit best. The second problem is that 12 weeks for testing eradication may not be sufficient. So we did not wait long enough because the immune-induced clearance is something totally different from the rest. And what we learned, and this is now, this part was published in the Lancet Gastroenterology, and this part is waiting for being published in Gut. AMAT, maybe not, because the first part was refused. And what have we learned here? Here we learned that those that, based on the H. pylori markers, 18 negative subjects, some of these, and 10 patients specifically, remained with chronic active gastritis in the absence of detection of Helicobacter. And we did not trust this, and in fact we eradicated also them. And only after eradication, these became also negative in sense of the histological assessment for active gastritis. That is very important, and you see one of the examples here with the micro abscess in the corpus gland with no detection of Helicobacter. And based on the trial design, this would have been categorized as cured. So that is a big problem. And here again, we treated them Two remained with active inflammation even after eradication, but 6 months later, they were completely healed. So what have we learned? The primary endpoint chosen not sufficient in the human challenge model. Follow-up after vaccine needs to select different intervals. And of course, we also learned that the adult model is capable of clearing Helicobacter by itself. On the other side, this is a suitable model to unravel host immune response involved in clearance. And there we are not exactly at the point where we would like to be. What about field study? That is the natural approach because infection occurs in childhood. Chinese trial, you know, after 1 year, children between 5 and 15 years, 3 doses, orally performed with the adjuvant given intranasally. There was a lot of debate if this is okay in the way it was prepared, but there was a good point to show that with the reaction of antibodies correlated, there was a protection. The criticism on one side, because of the way this was conducted, on the other side, with all the limitations, it was the proof of concept because vaccine-induced protection in these children from 5 to 15 years. What could be the immunomechanisms? That, as I said, could be learned, of course, from the animal experiments and from the human models that we have used in a very small number. The dual function of the immune system is on one side to allow the bacterium to persist, on the other side, the host to be prevented from inflammation-driven complications. In general, it's a Th1 response induced by Helicobacter pylori infection, but reading the literature, you find a mixture where Th1 and Th17 and maybe Th22 are important. Their relative contribution, however, are not yet clarified. There have been data on interferon gamma, IL-17A, and I think this is one of the studies where one can find all the informations up to the point, including the experimental point. So the interleukin-17 is a critical mediator, and we looked at it in our study. I just go very quickly over this. Sorry. I want to show back, maybe it's this here. No. No, here with the problem is the light. I need light to go back. This is my fault because I don't see where, you know, where it has to go back. That's back here. Okay, so what I wanted just to demonstrate here let's focus on interleukin-17, that in the vaccinated group, of course, you have a much higher response after challenge than in the placebo group. And the problem is that maybe we need a higher cutoff, a higher concentration of this in order to achieve the success. Here you have the two, again, the vaccinated and the non-vaccinated, the placebo. The development status, just to make a summary of what is currently available, you see that we have several of these approaches that have something in common. They all failed. I had the opportunity recently to see this gamma-glutamyl transpeptidase issue. Again, I'm not sure this will be continued. It's an interesting aspect because gamma-GT helps H. pylori to escape the host immune response. So if you provide a vaccine that eliminates this molecule of the bacterium, you may practically block the adherence. It works very well in all the experimental settings, but a final study has not yet started. Here you see the wild type, and here you see the deleted of the gamma-GT and the VAC-A. These are the two molecules that are essential for colonization in this. Where are we going from now? Should we reconsider the route, other factors? There are some hormonal candidates that show to interact positively with the immune system, but I don't think this will be the way to go. The way to go is more links between different approaches that involve the whole apparatus coming from the omics. And one of these approaches has been shown a few years ago, whereby analyzing the proteomics, they found 5 of the major candidates, major epitope, also activating epitopes on the host cells, VAC-A, BAP-A, SAP-A. I think, as I showed you before, we used VAC-A, CAC-A, and NAP-A, but if they are complemented, maybe the reaction is stronger. There is now this proposal of going into the called reversed vaccinomics. Reverse vaccination initiates with the genome sequences, and you have in silico, in vitro, models where you can test if these identified proteins are able to elicit a response on the host immune cells. So the designed vaccine that they have, let's say, based on some calculations in models, they are at a level that they could be tested in the human situation. But, and I come to the conclusion, for the moment, the human challenge model was not effective, or it was not optimally used. As I mentioned, the timing to follow up. However, we have mechanisms in humans that we can make use of in our further progress. Not sure what happens with this Chinese field trial vaccine that seemed to be very promising. This is important, multiple antigens, multiple epitope. I think, yes, this is a way to combine the administration. I think parenteral is probably the most reliable, because the oral depends on what I didn't give you comparative studies on this. The adjuvants are required. Aluminate, as we used, is very acceptable. The issue that we should conclude with is we should not give up. And there's a very good commentary by Philip Sutton that said that the problem is that we have, I need a young lady for the last time to show, because, okay. What he concluded is that industry is not willing to go on in this, because there is not big money, just the slide before, that is placed, and I know that even in discussion, yes, no, just leave it. Just leave it, it's not important. So the conclusion is, no, please don't, that we need absolutely not to abandon the concept, because there is a chance to develop a therapeutic vaccine that stimulates the immune system that could collaborate with one of the classical antibiotic acid inhibiting components. And the other thing is that if the governments at some stage, big countries, would help to go on with this, it is a wise thing. And in the worst case scenario, if we are not succeeding with the vaccine, it will help to understand better the pathomechanisms of disease. Thank you very much.
Thank you, Peter. So, Peter, can I just summarize to say that Helicobacter pylori is just so complicated that it has so many epitopes, and we are not able to find antibodies against these multiple epitopes? That would underline in one sentence that summarizes the problem. Well, am I right?
Not totally. How could you be? It would be easy if you were right. I would say we don't know. because, of course, there's a high genetic variability on one side, but there is also a limitation of the efforts on our side, you know? So there is no systematic approach to this. There have been many experiments, but none, even where David Graham and myself are involved in this ultimately Novartis vaccine. It would not have been the end if it not was again sold, and so it's an issue also of dedication. I'm not sure that we would fail if we commit ourselves totally to this. So that would be my vision.
You remember many years ago, people did talk about a therapeutic vaccine. And if you could find a therapeutic vaccine, of course, that's like 20 years ago. And then we said that, if you have a therapeutic vaccine and you go to China, for example, where they have 60 or 70 or 80% prevalence, then you don't need to treat with antibiotics, you just give them a vaccine.
You're right.
That is no longer, of course, the aim,
see,
isn't it?
Just to give you one idea, we have never looked at what happens if we use this recombinant antigen vaccine plus a PPI, where we give this immune stimulus and we totally suppress acid. It could work, but there's no study done, so that I'm complaining about this.
Yeah. And you feel that there is perhaps lack of commitment from pharmaceutical as well in trying to spend more money in developing these vaccines.
There would be combination of more antigens, combination of more let's say, a more intelligent way of doing an adjuvant. There is something that could be done, but not by a single industry. None will embark in this. I mean, we have now vonoprazan and amoxicillin. They say, why should Takeda or any of these companies embark in a vaccine? Those who have the power to do, they wouldn't. That's the experience we have.
Okay, thank you, Peter. Questions from the floor? If not, we have to stop the session. If no questions, thank you, Peter. Don't go down because I got to give you this beautiful certificate and we need to take pictures.
Okay.
Jimmy,
Okay.
it's you.
Thank you, Professor, for your kind introduction. First off, I would like to express my sincere thanks to Dr. E. He discussed with about the stool antigen test and the clinical trial, and I will present the trial, the result of this trial. And this is my disclosure. And as we know, Helicobacter pylori remains an important disease burden worldwide. And a recent systematic review and meta-analysis conducted by the Hong Kong group, and as well as Professor Peter Martiner and David Graham, have shown that currently it was estimated that about 4.4 billion people in the world remains be infected with H. pylori infection. And if we look at the prevalence in different parts of the world, we can see that the prevalence of H. pylori is highest in Africa, Asia, and South America. And they also try to analyze the time trend in the prevalence of H. pylori in different parts of the world. However, in their analysis, they still show that in the majority parts of the world, the prevalence of H. pylori remains high, except that in North America and in Europe. And their results showed that currently the overall prevalence was nearly 50%. And now let's look at the situations in Asia. And in Asia, the incidence of gastric cancer was the highest in Korea, Japan, and in China. And the systematic review showed that more than half of the population in these countries are infected with H. pylori infection. And if we look at the time trends of the prevalence in these countries, they found that there were no significant reduction in the prevalence of H. pylori in these countries. However, because the studies recruited in this systematic review were actually performed several years ago in most of them. And therefore, it is important to know the updated disease burden of this infection in the world. And according to the result of the systematic review and the meta-analysis, the prevalence of H. pylori was 35% in the United States. However, this year, a report from United States using the histology collected in the database, they found that actually in the prevalence of H. pylori has fallen to around 10% in the general population in United States, although the prevalence appeared to be higher in some population. And in the systematic review, the prevalence of H. pylori was also nearly 50% in Japan. However, more recent studies from Japan have actually shown a significant decrease in the prevalence of H. pylori, especially for those now born after 1970. Therefore, maybe it is important to survey the updated prevalence in many parts of the world. And this is another systematic review conducted in Japan. They try to analyze the changes of the prevalence of H. pylori in children and in adolescents. and they clearly shown a decrease in the prevalence of Helicobacter pylori. And in Taiwan, Professor Zhao Tang Lin has conducted a surveillance study with our Vice President, Professor Chen, 20 years ago. In their study, they have shown that in Taiwan, the prevalence of H. pylori was around 54%. However, 10 years ago, when I conducted a clinical trial in Taiwan, our data have shown that the prevalence of H. pylori has actually decreased to around 40 to 45% in adult in Taiwan. Then this might be an important question because if we want to prevent gastric cancer through H. pylori eradication, then we need to know how many people are now infected with H. pylori in the world. Then we can know what's the budget or how much money we need to pay for the gastric cancer prevention program. And because in the previous systematic review, the global prevalence, they only divided the prevalence for those studies published before 2000 and for those published after 2000. Therefore, I just collaborated with Dr. Chen to reanalyze, and we also try to identify more recent studies to see the changes in the more updated prevalence of H. pylori. We have shown that currently the prevalence of H. pylori is actually appeared to decline to below 40%, but the difference were still not statistically significant. Therefore, I think more data are needed in this region. And in addition to that, there is lack of the updated prevalence in many countries and in Asia Pacific regions. There are some other limitations of current evidence to evaluate the disease burden. The first is that actually the published studies are actually quite heterogeneous in their study population and in their methods to detect H. pylori. Even if they used the same method, the accuracy of the different kits might also be different. And therefore, I think it's better to design a study that are more homogeneous in the study design. And the third question is that current data, most of currently published studies only present the average prevalence in the population they studied. However, if we want to calculate the exact number of infected subjects, actually we need to know the age standardized prevalence in that population, because different selection of the population might lead to quite different results. And also, in some studies, they recruit not only asymptomatic subjects, but also symptomatic patients. And such kind of difference might also lead to a different estimate of the prevalence. And now I would like to let you know why we need to report the age standard prevalence of H. pylori infection. We can see that because it is well known that the prevalence of H. pylori is higher in the elderly or older people, then the different selection, if the population we selected for the study is different, then that might lead to bias in the estimate. For example, if this is the actual population, and if for study A, if their sampling is different from the original distribution of their population, and if it just reverse to another study, then the prevalence they reported would be actually quite different, and it's difficult to estimate whether the prevalence is overestimated or underestimated. Therefore, I think the best way is to report the age standardized prevalence of H. pylori in future reports on this issue. And the second part is then which test should we use to survey the prevalence of H. pylori? Currently, non-invasive test is the preferred test to do the epidemiological survey. And this includes urea breath test, our stool antigen test, our serology test, and UBT is relatively expensive than the other two tests, but its advantage, the advantage of UBT is it is more accurate, and usually the interlaboratory variation is maybe smaller compared to other tests. And for Helicobacter pylori stool antigen test and for serology test, the sensitivity and the specificity varies from different kits because if different kits, their accuracy might be different. And the limitation of Helicobacter pylori stool antigen test is that maybe some people, they dislike to collect fecal samples. And for the serology test, because we cannot differentiate active infection from past infection. Therefore, we tried to validate the accuracy of this V-strip, and it's Helicobacter pylori stool antigen test. And in this study, we compared the accuracy of V-strip with immunocard to detect the H. pylori infection using fecal samples. And the UBT was used as the gold standard in this study. And this is an open-label multi-center study in Taiwan, and we recruit volunteers as well as patients with dyspepsia. And UBT was tested in all participants. And these were the inclusion and the exclusion criteria. And we only recruit adult patients only. And this is the study flow, and this is the demographic characteristic of the study population. The mean age was around 44, and if we look at the prevalence of H. pylori in this population, we found that the prevalence was around 18% in asymptomatic volunteer, but was around 25% in those with dyspepsia. And the majority of the patients, the subjects were recruited in northern Taiwan. And our result showed that the V-strip was as accurate as the immunocard stat, the kit, and the sensitivity was and the specificity were both higher than 90%, and its accuracy was comparable with that of immunocard kit. And we also tried to calculate the age standard prevalence of H. pylori infection in asymptomatic subjects. We exclude symptomatic subjects in this analysis. And our results show that in northern Taiwan, the adjusted prevalence of H. pylori was currently 22%. And in summary, this trip has equivalent performance as the immunocard stool antigen test, and it has the potential to become a self-testing in vitro diagnostic medical device, and can be used for future epidemiological study as well as for gastric cancer prevention. And if we use the serology test to see the changes in the prevalence of H. pylori in Taiwan and subgrouped by age, we actually found the prevalence of H. pylori in asymptomatic subjects was significantly decreased compared to the result reported by Professor Lin. And in the next step, I think because there is lack of collaborative study on the updated prevalence of H. pylori in Asia Pacific region. Therefore, we just try to propose a collaborative study to survey the disease burden of H. pylori in this region. And we will recruit asymptomatic children and adult subjects with unknown history of H. pylori infection, and those with the following conditions will be excluded. And this should be a random sampling from a population. And in this study, we will try to collect serum samples as well as collect the fecal samples. I think in addition to test the prevalence of H. pylori, actually we can also collect the fecal specimen for microbiota study to know the changes in the gut microbiota in addition to Helicobacter pylori. And UBT will be used in a subgroup of population to validate the performance of the stool antigen test in other population. And it is estimated that we will recruit 10,000 cases, and we are thankful to the PBF Biotech because they agreed to donate 10,000 kits for the Gastroenterological Society of Taiwan to conduct this collaborative study. And we will also try to apply for the international collaborative fundings. And if you are interested in this proposal, you can contact with me, and we can discuss in the near future. Thank you very much for your kind attention.
Thank you very much, Professor Liu. Is there any question concerning this presentation? Peter?
Maybe since you are inviting 10,000 Asian Pacific regions, I would kindly ask you, please extend this to a few centers in Europe as well.
We are happy to do that. And Dr. Yi, he can also discuss.
We have just planned now to do 20,000 subjects in Germany based on the breath test. But I mean, after I saw this data, I think it would be worthwhile to look it up with the stool test because it's much simpler. You know, less, as you mentioned, all the less personal and so on. There's a lot of logistic advantages. One question. How will you perform this? Will you perform this at the doctor's office, or would you say the patient gets it, check at home, and then writes I am positive or negative? How do you plan to do this?
Okay. In our previous validation study, the tests were conducted in the laboratory of the hospital. But maybe in the future, in our study, we can try to validate the result from self-testing compared to the result from doctors or technicians, maybe we can see whether there is any discrepancy between the different performance.
In your Taiwanese study, what was the acceptability to bring stools
Okay.
to you?
Actually, we actually has you can see the study flow. Actually, because but the data cannot explain the actual acceptance rate, but the majority of patients, maybe more than 80% in Taiwan, they can accept to our protocol to collect fecal specimen for the test. But maybe different population maybe has different culture, and maybe it's also an important issue that deserves our investigation. Yeah, but in Taiwan, the acceptance rate is high, not difficult.
A problem when you do prevalence studies like that is the consumption of drugs like PPI, especially sometimes antibiotics. And how do you deal with that? Is it just a record from the patient, or do you look to national databases to be sure? And how far can you go back?
Yeah, I think we by their history, because if they are taking any medication, we would like to review what kind of drugs they are using, and I think we need to exclude those on PPI therapy or just receiving antibiotics within 1 month. I think in the future maybe, but the protocol I propose is just very preliminary. I think we need to discuss, because I think maybe we can discuss a proposal that other researchers can also use the same protocol. Maybe even we are not collaborative studies, but if we have the same study protocol, maybe in the future it's easier for us to analyze.
Dr. Yi, maybe we can also ask you together with Dr. Jing. Now, Francis made a very important point, that you don't know whether patients are on acid suppression or not. Did you ever consider to develop with the same technology adapted to just H. pylori DNA as a quick test? Because the DNA you would find at any condition.
I think that's our second generation. We may do the isothermal one.
It's too difficult. You mean it's the quantity is too low?
Yeah, I know.
You need the protein, and the proteins are only expressed if there are viable helicobacters. Is this what you say?
As it is right now, although our rapid test is pretty good, however, we always thinking about the next generation test. So what you're saying, that should we doing some, such as without a multi-temperature change, we use isothermal to do the H. pylori? That's possible. We're also working on quite a few tests with isothermal amplification format right now. So we are thinking about the future.
Is there any more question? No? So thank you very much, Dr. Li Yi, Professor Liu. Maybe we could ask now Professor Ming-Chang Wu to give the final conclusion.
Discussion, all right.
Distinguished guests, dear colleagues, thank you very much for your active participation in Asian Pacific Topic Conference. I am very grateful for our organizing scientific committee, especially Professor Ziming Liu. They put much effort to organize this symposium with the main theme of gastric cancer, especially focusing on relapse issue. After this meeting, we still have a consensus meeting tomorrow. I think another purpose of this meeting is to find unresolved issue and to try to have cooperative studies among different countries. And we also try to find some budget support to have this kind of cooperative project. I think gastric cancer remains a very important malignancy in Asia Pacific region, especially Helicobacter pylori infection rate is still high in some countries. Taiwan's experience can provide a reference standard, especially we had community screening and eradication experience. Finally, I would like to thank you, our internationally distinguished guests. I think your support is very important for our project to carry on. Especially we should, just like our Vice President Chen Jianren say in this morning about hepatitis C. I think if H. pylori is in an infectious disease, we should have method to eliminate, not only eradicate. For hepatitis C, now in Taiwan, we try to eliminate HCV infection in Taiwan, and the setting year is year 2025. So I think for Helicobacter pylori infection, although some controversy about whether this infection perhaps will have some beneficial effect, but I think many recent studies has confirmed this is indeed an infectious disease, and then the bacteria is pathogenic. So don't worry about whether we eradicate or eliminate it will lead to some adverse effect. Thank you very much for your attendance, and I wish all of you have a wonderful stay in Kaohsiung and in Taipei later. Thank you.
Thank you. Thank you, Professor Wu. Professor Wu, just allow us also to express a sincere thanks to you, to your society, to your hospitality, to your fantastic team, Professor Jinming, Xiu from Xiu, from Tainan, from Xiu's group. We really felt like home. I mean, you did more than you ever can do for guests. I think this is on behalf of all the people, even the ones that are not here. Thank you so much.
Thank you.
Professor, presidents first.
Yeah, you are president.
and very distinguished in Japan. And his major research has become over the clinical microbiology of Helicobacter pylori and the many distinguished publications. Today he will introduce us the new classification of gastritis using the Kyoto system. Professor Murakami, please.
Thank you very much, Chairman and ladies and gentlemen. So it's a great honor for me to be able to make a presentation today. So today's topic is a new classification of gastritis, how to identify and classify gastric precancerous regions. So this is a epidemiology of gastric cancer in Japan. So in Japan, prevalence of gastric cancer is still increasing due to the great aging in Japan. And so this is mortality. And so about 50,000 patients died by every year by gastric cancer for 30 years. 30 years, no change, but recent 3 or 4 years, gastric cancer is decreasing about 10%. So now 45,000 or so. And this introduction. In Japan, 2013, treatments for H. pylori-associated gastritis was covered by health insurance. In fact, H. pylori-infected patients in Japan can receive these insurance-covered combination therapies for the eradication. So before the diagnosing and treating H. pylori infection, an endoscopic examination is required to obtain a definitive diagnosis of H. pylori gastritis. And also, it is a gastric cancer screening. And now, we need a gastritis classification according to H. pylori status. So, Japanization of H. pylori treatment. These are conventional indications, peptic ulcer, lymphoma, and ITP, and after endoscopic treatment of gastric cancer. And now, from 2013, H. pylori-induced gastritis is an indication, and all H. pylori infected patients can receive eradication therapy after endoscopic diagnosis of gastritis. So this is a classical classification of gastritis, and in Sydney system or updated Sydney system, this classification, in this classification, histological division and endoscopic division was separated. And we need endoscopic findings according to histological finding. We need this endoscopic finding according to histological finding. And we have a Kyoto classification of gastritis. And recently, last year, this was, so the second edition of this book was published. So this book has an English version last year. And so this, the contents was 3 phases of gastric situation. Non-gastritis, gastritis means without history of H. pylori infection, and active gastritis, this is current infection of H. pylori, and inactive gastritis, it's a past history of H. pylori infection after eradication or spontaneous disappear of H. pylori. So this table is the endoscopic findings of this book. And so there are three patterns of situation according to H. pylori infection. So in active infection, these endoscopic findings has appears, and so atrophy, diffuse redness, and intestinal metaplasia, etc. And so this endoscopic findings are active gastritis, means H. pylori positive gastritis, spotty redness, like this, and so enlarged fold, tortuous fold, and a sticky mucus, and atrophy vascular marking, like this. And also, this slide shows active gastritis. So diffuse redness and nodular gastritis with NBI, and intestinal metaplasia. And so with NBI can find easily in metaplasia, and with magnification. So non-infection without H. pylori gastric mucosa without H. pylori, hematine, red streak, and the RAC, the specific findings of non-infection stomach. So this is the H. pylori negative gastric mucosa, no history of infection. So the fold is very thin and straight, and you can see a RAC on the lower curvature of the body, and the angularis, and the red streak like this. And in the antral mucosa, no atrophy. So RAC, regular arrangement of collecting venules, is a representative of H. pylori negative mucosa. So in the fundus gland, you can see the RAC when the H. pylori is negative. So with magnification like this, so in the fundus gland, collecting venules is like this, and this is no RAC, and this is a case of H. pylori positive case, and we cannot see a RAC finding. And post-eradication, the representative finding is map-like redness. So map-like redness, this is before eradication, and the mucosa has so swelling and the diffuse redness, and this is 1 year after eradication, the same patient. So like irregular mucosa appeared, and so in this irregularity, the irregular shape and the map-like shape and a little bit red area appeared. We call these findings a map-like redness. And this is also another patient, map-like redness, like this, with indigo carmine staining. And before eradication, you can see atrophy. And so after eradication, like this. And so sometimes, this findings is similar to 02C lesion, gastric cancer, or gastric cancer. And sometimes we need to we need to talk sometimes misdiagnosis. And this is a histology of map-like redness. Right side is a map-like redness, and the left is without redness. So the histologically, redness side is intestinal metaplasia with inflammatory cells infiltration. And so without metaplasia, foveal epithelium hypertrophy, like this, without inflammation. And the contrast, we can see, we can recognize map-like redness. So after eradication, what is occurred histologically? This patient is 62 years old male at the corpus mucosa with atrophic gastritis. And before eradication, you can see severe atrophy. There is no funded gland and severe inflammatory cells infiltration. And 6 months after eradication, the funded gland appeared a little. And 5 years after eradication, you can see much funded gland looks like a normal mucosa. This is a very big change. And in this, this is our study, 10 years observation after eradication at the 5 point of gastric mucosa, 5 point according to Sydney system. And like this, all at 5 points, all 5 points, at all 5 points, atrophy score gradually decreased after eradication. And especially the score of, this is at a lesser coverage of corpus, showed biggest change in them. And this change can decrease the risk of gastric cancer. So this is a systematic review and meta-analysis by Professor Sugano and H. pylori eradication on the incidence of gastric cancer. And from this review, the odds ratio is 0.46. Means eradication can make gastric cancer risk in half. So I will show features of gastric cancer after eradication. So first, the gastric cancer with H. pylori positive case. So there is a big difference H. pylori positive cancer and post-eradication cancer. So this is gastric cancer, 02C plus 2A, like this, with endocarmin staining. And with NBI, you can see clearly intestinal metaplasia here. And with magnification, normal mucosa, no tumorous mucosa and tumor. And so you can see the border of normal and cancer very clearly, like this. And so these are the irregular vessels, irregular microvascular pattern, like this. And the demarcation line is like this. You can see very clearly, like this. So demarcation line is very clear. This is H. pylori positive cancer. And on the other hand, cancer after eradication, This is a very severe atrophy, and so maybe 5 years after eradication case, here, spontaneous bleeding here, and this area, and this with NBI, and the sub-border is not so clear, and we called gastritis-like appearance, so continuously observed from surrounding non-cancerous mucosa. So this another case. So not clear gastric cancer after eradication, and so you can see irregular vascular, and so magnified more. Irregular vessels you can see, and maybe this is a border demarcation line, and so gastritis-like appearance here. So continuously expand from non-cancerous mucosa, and like this. And so we call epithelium with low-grade appear or gastritis-like appearance is a specific finding the cancer after the eradication. So like this, this is cancer after the eradication, and so these mucosa is expand from the normal mucosa, and so with histochemistry with Ki67, the expression of Ki67 decrease in the surface superficial layer. This is a comparison of positive cancer and post-eradication cancer. So positive cancer, the Ki67 can be found all layers, but post-eradication cancer, Ki67 was decreased in the superficial layers like this. So findings associated with the risk of gastric cancer, so there are 5 findings. Atrophy, intestinal metaplasia, nodularity, fold hypertrophy, and diffuse redness. And it is necessary to make long follow-up after the eradication, especially for these findings, which are considered as being in a high-risk group of gastric cancer. So I will show that these findings, 20 minutes? Okay? Okay. We call IEE image enhanced endoscopy. So it's very useful to take to see the high risk findings. So BLI and NBI. So for example, diffuse redness with white light and LCI. The border is very clear when using LCI, linked color imaging. And for atrophic gastritis, the atrophic border is more clear, like this. So this atrophic border. So this is clearer than white light when LCI is used. So intestinal metaplasia, white light, and LCI. So it's it's very useful to use IEE for the risk findings of gastric cancer. So this slide shows situation of H. pylori infection in Japan. So now H. pylori positive cases is being eradicated. Many cases are eradicated, H. pylori positive cases, and the eradicated cases are increasing. And H. pylori negative also there are many negative cases, especially in young generations. And so in the future, eradicated cases and the negative cases are majority. And the detection of gastric cancer will become difficult to endoscopists in the future. So this is conclusion. So Kyoto classification of gastritis is useful for endoscopic diagnosis of gastritis according to status of H. pylori infection. So this classification become possible to be used as endoscopic classification of gastritis and as identification of risk factors of gastric cancer. So gastric cancer after eradication is difficult to diagnose due to epithelium with low-grade atypia. Thank you very much for your attention.
Thank you very much for an excellent lecture. As usual, Japanese classification is very meticulous, and you base a lot more on morphology, what you can see on endoscopic appearance. So in my understanding, the Kyoto classification is trying to use endoscopic appearance to replace some of the histological diagnosis. But I'm a little bit concerned how much of interpersonal variations when you perform this diagnosis, based on particularly redness of the mucosa. That could be a little bit subjective, isn't it?
Thank you very much. It's a very important question. So, diffuse redness is so typical H. pylori positive finding, but individually different is exist. But there are many findings, H. pylori positive findings. It's not necessary to one finding, but if we suspect H. pylori positive, we can diagnose H. pylori diagnostic test, and it's very important, and not so strict classification. We can understand.
Right.
Yeah.
One comment. I find endoscopic gastritis persists after H. pylori eradication.
Yes.
Dr. Murakami, what are your comments on that? When we see endoscopic gastritis in those patients who are Helicobacter positive, even after successful eradication, confirmed on biopsy and UBT, etc., oftentimes the endoscopic gastritis remains. Is that your experience as well? My first question.
Endoscopic gastritis.
Yes.
Endoscopic gastritis means actually in Japan, there are many diagnoses of chronic gastritis, and it contains of 3 patterns of gastritis. In endoscopic gastritis, and H. pylori gastritis, and also symptomatic gastritis. Now in Japan, chronic gastritis means H. pylori positive gastritis, and endoscopic gastritis is endoscopic findings. It's not a gastritis.
Yeah,
Okay.
it may not be histological gastritis.
Yes, yes, right,
in the
right.
true sense of the word, but as an endoscopist, I'm sharing my experience that
Yes.
as endoscopists, after H. pylori is eradicated, when you put the scope in, oftentimes there's still red blotches, erythema, loss of capillary pattern, and that persists for years.
Yes, yes.
That's one thing. That's a pitfall when people do follow-up scopes. Number two, which is a common clinical problem, is many endoscopists like to biopsy. Biopsy.
Yes.
They don't use image enhanced like you do. They biopsy, and then it comes up as partial intestinal metaplasia or intestinal metaplasia.
Yes.
Not very detailed pathological report. You know, this is not going to a university lab or good lab, but this is a routine lab, and they put this sort of reports. So what is your recommendation? Because many doctors in clinical practice then go overboard and then recommend that these patients should have a scope every 6 monthly,
and
repeat
biopsy.
biopsies again.
Always
to me,
biopsy.
Yes, to me that is ridiculous. That's ridiculous.
So in Japan,
what are your comments?
In Japan, biopsy. In Japan, ESD was very popular for gastric cancer treatment. ESD is more cases than operation, you know, and for ESD, for treatment of ESD, biopsy is not so sometimes affect.
Not indicated. You would not do that, isn't it?
So yes. Yeah. So we have this classification, and in Japan we recommend if you want to biopsy, please small size of biopsy, and to do not affect the ESD treatment. We recommend in Japan for endoscopists.
But in Malaysia, I think we have to move on, if possible.
Okay.
Thank you very much. And Professor Shi is going to present to you a certificate of appreciation. Thank you, Professor Murakami. Thank you. The next speaker is Professor Xu Bo Chang. He's my co-chairman. Professor Xi is a professor and chairman at the Department of Medicine in National Cheng Kung University. He is an expert in gastroenterology, microbiology, and immunology, and he has received numerous awards in the past years, particularly on his work in Helicobacter pylori. Today he's going to give a lecture on a very important topic, which I'm very interested in, is who needs surveillance endoscopy and how. Please welcome Professor Shi.
Thanks for Professor Song and dear colleagues and from all the audience. Good afternoon. It's my great pleasure to introduce who needs surveillance endoscopy and how is the strategy after H. pylori eradication. In my brief talk, I will highlight for 4 aspects. The first is to introduce the low endoscopy, and then to identify who is the current situation to need the surveillance endoscopy. Indicate the one who remain at high risk after H. pylori eradication. And then we have some point to introduce the risky group with the precancer regions and during the follow-up, and then introduce the current situation of the strategy in the worldwide. The low endoscopy, I think everybody are very familiar to perform up GI endoscopy, and just like the Kyoto classification says, you may use the endoscopy to extend the histologies. So before H. pylori eradication therapy, the endoscopy can be arranged to screen the status of H. pylori and to detect the related gastritis pattern, especially with topography sampling to take the sampling of the histologies for define the precancer regions. And after the H. pylori therapy, it will be very important. As we know, it can really improve the gastric cancer control. However, there are still have a certain portion in the risk to have H. pylori eradication, but the cancer still can develop in the follow-up. So the meta-analysis by Professor Lee showed that it will be very attractive to see a very high risk reduction to 0.6 by H. pylori eradication to decrease the gastric cancer. And it will be very cost benefit, as shown in this morning by Professor Zheng. He said, if the ICER less than $50,000 and then it will be very cost effective to use the H. pylori eradication to serve as primary and secondary prevention for the gastric cancers. And in Taiwan, we use the National Research Trace by Professor Zheng. He said that the test and treat program will be very cost effective if even you start earlier since age less than 30s, and it will be only $22,000 to save the life year expenditures. And however, after the H. pylori eradication, we should keep in mind they will still have certain portion to have progressions of the new cancer development. And then they will have a 10-year prospective cohort in Netherlands, and then include nearly 10,000 people to follow up more than 5 years, and then find the age more than 45, and if they have the presence of the precancer regions such as the atrophy, intestinal metaplasia, and the risk will increase from 1.3 to 6 to near 4.4, and if the severity of precancer region is very evident, and it will be more than 4.4, even up to 44. So a more interesting study to say that a longitudinal follow-up in Japan, they find that equal to 0.3% per year. If your stomach have the first endoscopy to show the intestinal metaplasia, it will become a precursor and a high-risk precancer regions. And the cumulative index will be especially higher within the first year to nearly 0.7%. And in every 1 year, cumulative for 10 years, you will still have 0.3% of the intestinal metaplasia to progress to cancers. And how about to use the endoscopy surveillance to follow up the pre-malignant lesion? It's not a new story. And based on the gut published in 2002, they find if you annually survey the endoscopy, you will have a higher chance to get earlier stage tumors in high proportions. In contrast, if you do not use the endoscopy surveillance regularly, and once you find a tumor, you will be more than 60% to be advanced cancers. So they will have two benefits. If you follow up endoscopy, you will find more earlier cancers. Accordingly, you will have a good 5-year survival rate to more than 50 years. And the next important question will become, who should be treated H. pylori eradication to improve the gastric cancer? And then after H. pylori eradication, how to follow up the patients? Up to now, they will have two important categories to define. One is the age, and the other is the presence of precancer region at the index endoscopy when you conduct before the H. pylori eradications. So it will be a very important clinical impact for us to answer who needs a surveillance endoscopy and what is the optimal strategy. For a risky who, we can summarize the risky background such as gastric cancer family, or those have endoscopy surgery or either operation by EMR-ESD to have the tumors, and then after H. pylori eradication to follow up. Recently, we have some precancer region definitions modified by OLGA and OLGIM. And then maybe there are some early marker earlier than OLGA, OLGIM, such as the blood sampling to test the pepsinogen 1:2 ratios, or using the new concept about a corpse gastritis index or a new precancer region as SPEM. So in contrast to the Kyoto classification, just use endoscopy. because endoscopy, just like Professor said, it will be very subjective and very encountering the interpersonal bias or interpersonal training set. So it will be very not easy to communicate from the international data to serve as a longitudinal cohort. So tentatively, the presence of premalignant lesion, taking the biopsies to sampling topography from both entrance and the corpus to merge into the OLGA or GIM has become the current suggestions in many international worldwide consensus. And such as OLGA, OLGIM originated extension the Sydney system, and after the 1994 revised in Houston and the 2005 to have OLGA. But OLGAs usually have more interpersonal bias even in pathology. So the more reliable definition using the OLGM starting in 2009. And we next move to see the pathology will back up our endoscopies. And what is the timing to decide the surveillance endoscopy, and what is the suitable interval? This study is very interesting, published in Cancers, and you find that if you do endoscopy per interval, it's 1, 2, 3, 4, 5. And once you more than 3 years, and the risk to have the advanced cancers will be higher. Contrastly, you can see in other words, if you can follow up within 3 years, and the risk to have advanced cancer will be not significant. So at least we must conduct the endoscopy follow-up for those in need, especially those with precancer regions, in average within 3 years. And then the other ratio reduction will be nano 2.6 and 2.09 if they are in the older people or even have the gastric cancer family history. It indicated that in average for 3 years, but certain patients, such as the senior patients or those with gastric cancer family or other risk group, must be followed in more close intervals, less than 3 years. And how about such cost-effective or endoscopy surveillance for gastric cancer control? As this morning, Professor Zheng has clearly said, H. pylori eradication to reduce the gastric cancer really improve the gastric cancer control and with many cost benefits. And there will be another second cost benefit functions by endoscopy surveillance. The endoscopy surveillance for gastric cancer follow this US surveys to see if you have 10-year gastric cancer incidence to near 3%. As you can remember, I just introduced that if the patient have intestinal metaplasia, they will have 0.3% per year. And then multiple 10 years, it will near to 3%. So if your countries have, or in general population have the 3% in the 10 year to have the gastric cancer risk, it will be cost benefit to be less than 50,000. So up to now, it will be generalized accept that the gastric cancer control by the endoscopy surveillance to those with high-risk group as intestinal metaplasia will be cost benefit. So based on these findings and the MAP2 guidelines in European study group and the EHPSG, they conduct the first consensus to suggest who need to receive the management of precancer conditions, and they well recommended that endoscopy surveillance should be offered for those with atrophy or intestinal metaplasias. And at the time in 2012, they suggest every 3 years after diagnosis. And how about they are revised in the recently in these years? They you define the MAP2 consensus. They even extend into 2 new concepts. They find that for those with mild and only moderate atrophy, and then confined only in entrance, maybe they have no evidence to recommend surveillance. But nearly 100% agrees, but the evidence remain moderate. So there were still some new story to be addressed over here. Everybody can think if they are only mild atrophy and confined only to entrance, you will only without endoscopic surveillance. Maybe this is a current suggestion, but later I will introduce some new data. You may have another considerations. In contrast, for another using the high quality endoscopy, and you conduct every 3 years must be suggested for those with extensive atrophy or IM, especially with the OLGA, OLGIM in advanced stage as 3 or 4. And there are more strong recommendations, but evidence that even only raw quality. So I think everybody still have some important work to conduct in the future to see what is the real impact of such guideline to change your clinical impact. And I am very interested to this publication just published by AOMA in GUT in this year. They use the surveillance of pre-gastric cancer regions, a multi-center cohort, but this is conducted in the low incidence regions. They find that in the Netherlands or Norway, they use the first guideline in MAP1 in 2012, and then follow up the surveillance endoscopy in nearly 300 patients and conducted nearly 800 surveillance endoscopy. It's very interesting they forced the paper to include oral GIM range from 0 to 5 longitudinally to follow up even up to 5 years in the longer one and in average for 3 years. How about the findings? It's very interesting. If you follow to the MAP2 guideline, you will say you just need only to follow the oral GIM 3 and 4. But during the follow-up, the case to have 0.3% per year to have the new cancer development. But it's to my surprise, it will be very interesting to see they are initially oral GA just very low and only confined to entrance. Moreover, they are only half of them with advanced oral GIM 3 and 3 and 4. So I personally suggest for oral GIM 3 and 4, really you must follow the MAP2 guideline. But for those with atrophy only confined in entrance, we should be keep in mind there remains some risk group to have the risk to develop cancers, especially within the follow-up 3 years. They use a very interesting biomarker validation to indicate using the pepsinogen 1:2 ratio. If they are more than 3, it will be indicate less atrophy. And then if they are less than 3, they will have a higher risk, and then to combine the oral GIM 3 and 4. It's very interesting in this paper, they find all are the patients with the new development of new problems after H. pylori conditions can be really nearly 100% identified. So they indicate the blood biomarker must match with the histology to indicate who near the longitudinal surveillance, even in the close follow-up period. So the MAP2 and the MAP1 and MAP2 guidelines, we must remind for patients with advanced precancer regions, you need to follow up every 3 years. In contrast, maybe for those with only confined to atrophy in entrance, we need a new marker, and there remains some story to be followed up. I suggest in our team, we find that the corpus gastritis index, and then it will indicate more SPEM, and then have a higher risk even earlier than oral GIM and oral GA. So it will be a very promising marker to indicate who with just only atrophy, and then you can test the corpus gastritis pattern, and then you can define the risk. And when you conduct the surveillance endoscopy, what is the optimal content you must consider to apply? It will be not enough to use light endoscopy only. You just can see just in my previous professors suggest that you must need some more high resolution, such as NBI or ICE or NM with or without magnifications. And then when you conduct the screening endoscopy or the surveillance endoscopy, you must take care to take the topography biopsies covering both the entrance and the corpus. And in entrance or corpus, you must respectively to care about at least the 2 biopsies, one from laser curvature and the other from the greater curvature. At least the 4 samples, it will help you to composition into the oral GA and the oral GIM. And then you will be easy to define the stage 3 and the 4, and then need the cross follow-up. But you can see some patient will be follow-up longer or some patient can be shortening. However, in the worldwide consensus, they find that such a concept just within 70% countries or joiner to be introduced worldwide. So I think this will be more important for the international communications with to study this concept to take the topographic biopsies if you need. And then there are additional diagnostic factors to help you to identify who can be tested endoscopy surveillance more earlier, such as the family history with gastric cancer and those with the SPM or CGI impotence. And then maybe some bacterial virus factors are very toxic, and there will be in the next topic to present about the host genomic factors or the tissue factors can be made a more reliable precision medicine for your selection to the timing for the surveillance endoscopy. This is very interesting, and the pepsinogen 1 blood markers and the pepsinogen 1:2 ratio less than 3, it will be very good atrophy indicator. However, the worldwide distribution for the availability can be remain very diverse in many nations. It's less than only 50% in 2012, and now just less than 70%. So I think it must take into the consideration to use the non-invasive biomarkers. I personally suggest, as some recent our data show, that the TF2 in the serum can be indicated to the SPEM, especially for those with corpus pattern gastritis. So it will be a new marker to adapt for some help. In addition, some microRNA, especially those can be checked in either tissue or serums, will be another permission factors. So finally, I take a very quick conclusion that H. pylori eradication really can improve gastric control with cost benefit. To be important, endoscopy surveillance is also many cost benefit if your countries is a high-risk area to have precancer regions, at the more than 0.3% per year to have annual cancer instance. For who define you can use more age biomarker, historic pattern, or precancer region instability to define the time strategy for the endoscopy surveillance. However, just keep in mind, the MAP2 guideline maybe it needs us to refine with new data in future, as some only entrant atrophy may still have development gastric cancer. Thanks everybody, I end my talk, thank you.
Thank you very much, Professor Xu. Excellent review on the topic. In my locality, a lot of doctors are doing, in my view, too many endoscopy surveillance without any risk stratification. And you have pointed out that we should look at the topography as well as other demographic data to classify who requires. And also, according to European consensus, there should be more biopsies instead of just 2 + 2 + 1 as the Sydney classification. So do you think that future research in this area should focus more on whether this increased number of biopsies or the so-called targeted biopsy based on white light or NBI with or without biomarkers? What do you think will be the... I think at the present moment, the evidence is still very inadequate. So do you think there should be more research, and if so, in which areas?
Thank you, Professor Song's good question. The question is very difficult. So based on the current situation, we are now at the standpoint to keep on to take the topographic biopsies and then to follow up longitudinally. But it's just the Kyoto classification says, if you follow up the endoscopy, I personally feel before endoscopy, the gastritis pattern or endoscopy image may be not so complicated. So I personally agree the professor said that the post-follow-up, the endoscopy is more complicated. So there are two new stories to develop. One is to help run your biomarkers in the tissue or from the serum. And the other is based on the artificial intelligence for the endoscopy image analysis. I think there are two new stories for us to cooperate in future. But tentatively, MAP2 guideline can be well recommended, but there are short pitfall for those with confined atrophy only. They will remain another two groups within the same. Thanks.
Questions from the audience? If not, I will present to you the certificate of appreciation. So our next talk is to be given by Professor Ki-Guan You. Professor You is a very well-known gastroenterologist in this region, particularly in the area of gastric cancer research. He is the principal investigator of Singapore Gastric Cancer Consortium, and he's also the deputy chief executive of National University Health System in Singapore. Ki-Guan is an old friend, a good friend, and he has got some new ideas on molecular markers in determining the risk of gastric cancer. And he's going to give us a talk on what is the role of molecular marker in the risk stratification of future gastric cancer risk after H. pylori eradication. Please welcome Professor You.
Thank you very much, Mr. Chairman. I'd like to thank the organizers, Professor Wu and Professor Liu, for the kind invitation. Delighted to be here to share our results. I think as previous speakers, Professor Xu and others have pointed out, there is a residual risk for gastric cancer even after Helicobacter eradication. And we believe that some of this risk is due to genetic changes have already occurred in pre-malignant lesions. So this is what I will address in my talk. Bring you greetings from the National University of Singapore. So I will talk along these lines, the residual risk of cancer after Helicobacter eradication, a study that we've done that gives us further data on this topic. What are these genetic alterations in intestinal metaplasia, and conclude on the following steps. I think you've seen various data on this in the meeting. Just to summarize that many studies have shown there is a risk of gastric cancer even after you eradicate Helicobacter, and the incidence rate of gastric cancer is between 1 to 200,000, 1 to 200 per 100,000 per year. We believe that this is due to the presence of pre-malignant lesions such as metaplasia, atrophy, or dysplasia. So I'll describe a study we have been conducting in Singapore, GSEP, which is the Gastric Cancer Epidemiology Program. And we performed this study to investigate the natural history of pre-malignant lesions in the stomach, and hopefully to propose a cost-effective screening algorithm. So GSEP was 3,000 subjects recruited in Singapore. They were Chinese, aged above 50, and they were endoscoped over a 5-year period, 3 times at baseline, year 0, year 3, year 5, with collection of biopsies and blood materials. And the endpoint we're looking for was adenocarcinoma or high-grade dysplasia. We recruited 2,737 subjects. Male and female were about equal. There was about 21% rate of smoking, either past or present. Helicobacter infection was present in 43%. And we performed the pathology according to the Sydney system. So 24% of subjects had atrophic gastritis, 43% had metaplasia, and we defined it by the OGIM scoring system. So the majority of these were OGIM 1, and about 33% were OGIM 2, 3, and 4. So over the 5 years of the study, about 21 patients developed early gastric neoplasia. This gives an incidence rate per year of 0.16% per year. And these 21 subjects all were found to have very early EGN. 19 were intestinal type, 2 were diffuse type, By AJCC staging, they were all stage 1 or stage 0. So very early lesions, they were removed by ESD. And these were the risk factor analysis. So if we look at the right, age was significant, Helicobacter infection history, pepsinogen, atrophy as shown by pepsinogen or by histology, and metaplasia. So metaplasia was the single most influential risk factor. Just metaplasia alone was increased the risk by 5.8 times compared to having no metaplasia. And the risk continued to increase with higher scores of metaplasia. So in this slide, I've shown the incidence of developing early neoplasia according to their OGIM score. OGIM 2, 3, and 4 is more diffuse, more severe metaplasia. And you can see that as the OGIM score increases, the incidence of developing early neoplasia also increases. So maybe at OGIM 2 and above, you see an increased rate of developing early neoplasia. We know that metaplasia is not the same, and the incomplete metaplasia had a much higher risk than complete metaplasia. And the progression to developing early neoplasia from having metaplasia further increased if there was smoking history. So if the subjects continued to smoke, then they have an increased risk of developing neoplasia. Finally, this is the median time for developing neoplasia from metaplasia. So compared to the reference baseline, in OGIM 2, if they had OGIM 2 at baseline, it took about 4.2 years median to develop early gastric neoplasia. If they started with OGIM 3 or 4, meaning more diffuse, more severe metaplasia, the median time of 1.6 years to developing early neoplasia. And you note that 75% of the neoplasia occurred before 2 years in OGIM 3 and 4. So we went on to do sequencing for metaplasia, and this is probably the first study of genomic sequencing in intestinal metaplasia. So in total, we did 148 subjects. 83 were in OGIM 3 and 4, moderate and marked metaplasia, 22 with mild metaplasia, and the rest were normal. So we looked for genome sequencing, methylation and epigenome, and copy number changes. So what we found was that if we looked at DNA mutations, in metaplasia, there is fewer mutations compared to gastric cancer, but nevertheless elevated above baseline. So metaplasia is intermediate in presence of mutations. Secondly, the copy number changes were increased in patients with metaplasia. And in intestinal metaplasia, we also found shortening of the telomeres. These are all indications of DNA damage. Oops. Sorry. We also looked at methylation changes. So we found that metaplasias exhibit hypermethylation compared to normal gastric mucosa. Lastly, we found that in people with metaplasia, if you have IM from different anatomic positions, so IM in the antrum and cardia, they are a common mutational signature, suggesting that it's caused by a similar environmental process, and very likely this is Helicobacter pylori. So to summarize the genomic changes, we found 3 main genomic alterations associated with metaplasias that progressed to stomach cancer compared to those that did not progress to cancer. And these were increased mutations, shortening of telomere length, and copy number alterations. So we propose that these 3 genomic markers can be used to identify a subset of metaplastic patients with a very high risk of progressing to gastric carcinoma. So in summary, we agree that surveillance is indicated for people with pre-malignant lesions. The GSEP study provides some evidence for risk stratification using the OGIM score. We've identified the genetic alterations in metaplasia that are associated with progression to stomach cancer. And we propose a prospective study to validate this molecular test in order to provide data to guide future practice. So in future, it could look like this. If the molecular test is successfully validated, we could use it to identify patients with metaplasia or atrophy that have a very high risk of progressing to stomach cancer and who should receive the endoscopy perhaps every 2 to 3 years. And patients without these genetic changes, I think we could have longer surveillance intervals. Therefore, we would focus surveillance on the very high-risk group. Thank you very much for your attention. I'll be happy to answer any questions.
Ki Guan, very interesting topic and very important findings in your cancer cell paper. You have found 3 genetic markers which predicts development of gastric cancer from atrophy. A couple of years ago, we have studied epigenetic markers in the development of gastric cancer. Do you think that would also be playing some role in risk stratification?
Yes, excellent question, Joseph. So we did find epigenetic changes. So there are methylation changes in intestinal metaplasia compared to normal mucosa. So in methylation, there is, in metaplasia, there is hypermethylation. But this did not differentiate the IMs that progress to gastric cancer. So our explanation for this, our interpretation is that methylation is a very early step. It occurs by the time you have intestinal metaplasia, but it didn't help us to differentiate those that went on to develop stomach cancer. Whereas the other 3 genetic alterations, mutations, copy number changes, and telomere length, were differentiators for those that progress to stomach cancer. So I think it's early changes versus late changes.
But these markers can combine together, perhaps, in the prognostication.
Yes, yes.
Professor Sugano.
Yes, thank you. And I always cite your paper published in the Cancer Cells. I wish David is still, he is gone now. But he was wrong to assert that intestinal metaplasia never gives rise to gastric cancer. But your data clearly shows that the part of, or a subset of intestinal metaplasia certainly give rise to gastric cancer. And because the change in chromosomal changes occur at the stem cell level, right?
Yes.
Am I correct? So these some critical changes actually occurs at the stem cell level of intestinal metaplasia. Intestinal metaplasia itself occurs at the stem cell level. That gives rise to all the different cell types. So in addition to that, other genetic changes, including chromosomal instability occurs. Then it really goes to the cancer pathway. And my question is that one, what was the minimum size of gastric cancer or dysplasia you detected during the follow-up period? Because unless the neoplasia grows to the certain level, it certainly evades detection by endoscopy. Even by the Japanese experienced one, 3 millimeters of the size is almost the detection limit. So what was the data on your follow-up cohort?
Sugano. Thank you, Professor Sugano. The early neoplasias in our study all came from the GSEP study. And the smallest size we detected in the GSEP study was 8 millimeters, almost 1 centimeter, and the rest were bigger than that. So that was maybe the limit of detection in our hands. But you're right. I think there will be a certain limit, and then maybe the eyes cannot detect it.
The second point that I'd like to ask you is that you define a subset of intestinal metaplasia that has a high risk of developing into the gastric cancer. Is there any differences between those without progression and those with progression from endoscopical, macroscopic features? For example, certain intestinal metaplasia can be detectable by routine endoscopy, which has a little bit elevated type. We call it the specialized intestinal metaplasia type. Those are high risk or not? Or you have identified any features that can be identifiable by a routine or a magnified endoscopy levels? That is more important because all the sophisticated analysis by all the molecular typing is impossible in the clinical level. So if you have any features that can be identifiable by routine or sophisticated endoscopy level, that will be more useful to identify those high-risk groups. That's my question.
Thank you. I think that's an excellent question. So I think in endoscopy, we can see the lesion and we can see the background of the stomach mucosa. In the lesions alone, we didn't detect any features that predicted progression. But in the background, the ones that developed into early neoplasias were more in the OGIM 3 and 4. So they were the more diffuse and more severe metaplasias.
Thanks for...
Maybe one more short question. These days, the LCI system, linked color imaging, can pick up intestinal metaplasia on the macroscopic level by endoscopy. And among those, intestinal metaplastic mucosa, if you identify the different colored region, that usually denote dysplastic lesions, then I'm suspecting that some of the dysplastic region might be, I think, surrounded, although it might be a very small one. But these days, it's possible to pick those small lesions by specialized method. So that's what I'm asking.
Okay.
Thank you.
On behalf of the committee, we invited Professor Song to give you the certificate for the wonderful lectures. Thanks, Dr. Ye. Yeah. And we move to the last talk of this symposiums. We invited Professor Wu Junying from Taiwan, VGH, to give the talk about what's the role of molecular, the chemotherapy preventions needed in patients with extensive gastric atrophy and intestinal metaplasia. I briefly remind that Professor Wu is very distinguished scholar in Taiwan, especially famous for the national registry of the database, and also he's a lawyer, and also he has very distinguished focus on the microbiota, and now is the president of the microbiota in Taiwan. Yes, we introduce Professor Wu to give this wonderful talk. Professor Wu, please.
Professor Song, Professor Xu, thanks for Professor Xu's introduction, and also thanks for this privilege to give a talk to discuss about this chemo prevention needed in patients with extensive gastric atrophy and also intestinal metaplasia. Unfortunately, the evidence regarding this issue is quite important, but very limited evidence could be shared here. Also, you know that the stomach cancer carcinogenesis will going through a lot of the pathways, including the H. pylori infection to induce the chronic gastritis. Then with the other environmental factors such as the household consumption or smoking, we will develop to the atrophic gastritis. Then after some of the oxidative stress will develop into the intestinal metaplasia, then to the dysplasia, then the stomach cancer. And there are a couple of the risk factors as mentioned before. They are the very beautiful review in this CGH 2 years ago. According to the H. pylori, several of the host genetic factors, such as the previous section, including the genes factors among the patient with the IMR with the atrophic gastritis could be related with the future development of stomach cancer. And also some of the environmental factors has already been emphasized in many previous studies. And in the abstract 5 consensus, they emphasize on the importance of the H. pylori infection, and also emphasize on the precancerous lesions, and especially the statement 6 mentioned about the H. pylori education reverse the stomach atrophy if the intestinal metaplasia is not present, and arrest the progression of the neoplastics to the lesions in a subset of the patients. As we know that the prevalence of the atrophic gastritis and the intestinal metaplasia is not quite rare. It's the meta-analysis published 5 years ago in the European Journal of Gastroenterology. The prevalence in the low stomach cancer incidence countries and the high stomach cancer incidence, the prevalence can range from the 20% to more than half of the populations who are actually infected with the atrophic gastritis. And the intestinal metaplasia prevalence is quite a similar prevalence compared with the atrophic gastritis, and actually is similarly lower in the low stomach cancer incidence countries. And the atrophic gastritis and also intestinal metaplasia is similarly higher in the stomach cancer first degree families. In this metastasis, we can find that the odds ratio could be twice a higher risk with the atrophic gastritis in the first degree stomach cancer relatives. And also the relative risk for the intestinal metaplasia will be even higher with the odds ratio 2.2 in the first degree stomach cancer relatives. And it's a paper published 4 years ago in the BMJ. The study was based on the Sweden intestinal metaplasia patients. And you can see the patient not only with the intestinal metaplasia, but also with the dysplasia. The 15 years cumulative incidence of stomach cancer is about 30%. And the those without dysplasia, the intestinal metaplasia patients, after the 15 years of follow-up, the cumulative incidence is about 1.2%. And it's the data we published 3 years ago in the JCG. We found that after the follow-up of the 15 years, the patient with the intestinal metaplasia will have the 3% to develop stomach cancer. If we further classify these intestinal metaplasia patients into the patient with the dysplasia or without dysplasia, the 15 years cumulative incidence for the patients with the dysplasia, the risk of the stomach cancer is about 20%. It's much significantly higher compared to the Sweden patients. But however, the patient without the dysplasia, only with the intestinal metaplasia, after the 15 years of follow-up, the cumulative incidence is only 2.4. It's just a little bit higher compared with the data reported in the Sweden countries. And also we can see that this paper published in Professor Li Yijia 3 years ago. We can find that the H. pylori education to reduce the stomach cancer in the lowest incidence risk area. The incidence rate ratio is about 0.80, about 20% risk reduction. And the H. pylori education effect to reduce the stomach cancer in the intermediate or in the high-risk incidence countries, the incidence ratio is about 0.49 or 0.45. It means that we will reduce about twice the stomach cancer risk in the intermediate, also the highest incidence countries. And then there's another very interesting metastasis regarding the H. pylori combined or not combined with the antioxidants of the vitamins. And the authors found that if you eradicate the H. pylori without adding the antioxidant or without adding the vitamins, the relative risk is only about 0.82, only reduced about 20% the stomach cancer risk. But if we treat the H. pylori and also add on the antioxidant, also the vitamins, the relative risk is about 0.52. It means about half of the stomach cancer risk could be reduced by eradicate the bug, also combined with the antioxidant or the vitamins. So it means that the roles of H. pylori infection, but also the inflammation status after the infection will play some of the very important roles in the following stomach cancer carcinogenesis. And this paper published 4 years ago, the author concluded that H. pylori eradication in the primary stomach cancer or for the meta-chronic stomach cancer, they actually H. pylori reduced the risk of the further stomach cancer risk. So according to this meta-analysis, we can conclude it's never too late to eradicate H. pylori even after the occurrence of the stomach cancer. And the author further classified the patient according to their baseline, the stomach mucosa conditions, into the patient with the intestinal metaplasia and dysplasia, or the patient with only the atrophic gastritis. You can see that the effect of H. pylori will be more prominent in a patient only with the atrophic gastritis, and it has become more limited in patients with the IM or with the dysplasia, with the relative risk is only about 0.88. And then we move to the other potential chemo-preventive strategies other than H. pylori eradication. In this paper published in the CGH, we can see that some of the agents such as Castril, the aspirin, the non-steroid, anti-inflammatory drugs, also these will potentially to inhibit the process from the chronic inflammation into the other precancerous lesion of stomach cancer. There's the paper we published in the Journal of Clinical Oncology a couple years ago. It is a population-based study. We compare the patient with the regular NSAID use with more than 28 days per month and continuous for 6 months, compared with those who never prescribed with the NSAID. And we found that the NSAID regular users will be associated with significantly lower risk of stomach cancer during the 9 years follow-up. And we classified the patient according to the HP status. And we found that the chemo prevention effect of NSAID is especially higher in HP infected subjects and not so high in the non-HP infected subjects. I think it's also related to the chronic inflammation status induced by the H. pylori in chronic infection. And also, its paper is a meta-analysis regarding the potentially chemo-preventive effect of aspirin to reduce the stomach cancer risk. And we can find that with a very low dose aspirin, the chemoprevention effect with the relative risk about 0.63, it means about reduce 1/3 of the stomach cancer risk. If we increase the dose of aspirin, actually the chemoprevention effect is not so prominent as the low dose aspirin. And then there's another beautiful study published by the Chinese Hong Kong University. It's a territory-wide population study. And you can see that the aspirin use were actually related with the reduced stomach cancer risk, no matter with the Papez score adjustment or without the Papez score adjustment. You can see about 2/4 of the 1/3 of the risk of the stomach cancer will be reduced. And how about the role of the statins? As we know, statins not only control the lipid level, the statin is also related to the reduce the chronic inflammation, also induce some of the cell cycle arrest. And in the meta-analysis based on the 11 studies, we can see that statin use were actually related with reduced stomach cancer with the relative risk to reduce about 30% of the stomach cancer. Now, how about the dysbiosis? It's the most hot topics about the potential stomach dysbiosis related with the future occurrence of the stomach cancer. In this beautiful study published in Professor Song's groups last year in Gut, we can see that the atrophic gastritis or the intentional metaplasia were actually with the lower the bacterial diversity compared with the patient only with the superficial gastritis, and a little bit higher in the stomach cancer patients. And you can see higher here in the heat map, there are some of the different bacterial species were actually reduced in the patient with the pre-cancer stages. So it's also provide and highlight the potential chemopreventive targets in the patient with the gut dysbiosis. So should we apply the chemoprevention? For example, the studies, the NSAID, to all the patients with the extensive atrophic gastritis or with the internal metaplasia. Since the risk of the stomach cancer in patients with IM is especially higher in the intermediate or high risk of stomach cancers, we suppose we should emphasize on the personalized risk prediction based on the patient's demographic data. For example, this is the paper we published 4 years ago. We use some of the patient's parameters, such as the patient's age, the paper ulcer site or the complication, paper ulcer eradication, NSAID use duration, and also the endoscope follow-up indications. And we can classify the patient into the 4 quantiles. We can see that the patient with the high-risk quantiles will have significantly higher risk of the stomach cancer among the paper ulcer patients. So it means that in the big data era, it's become possible that we can calculate the individual's patients with the atrophic gastritis or with the intentional metaplasia and to justify the use of the chemopreventive strategies to reduce his or her future stomach cancer risk. So in conclusion, we say that the atrophic gastritis and the intentional metaplasia are quite prevalent and common, especially in the stomach cancer first-degree relatives. And the stomach cancer risk in the AG or in the IM are significantly higher compared with the general population, especially with the higher stomach cancer risk countries. And also, H. pylori education is been confirmed to be beneficial to reduce in a patient with the precancer stage to reduce the stomach cancer risk. And with the potential chemopreventive strategies by prescribing NSAID, aspirin, the statins, there are some of the evidence to support the potential beneficial effect in the AG and the IM patients. But however, we are still need more studies to confirm these clinical observations. Thank you for your listening. Thank you.
Professor Wu, a very interesting talk. You have listed a number of drugs that may be useful to prevent gastric cancer development, but you have not mentioned the possible adverse effects of using these drugs. For example, NSAID and aspirin causing ulcer or coccyx that may increase cardiovascular risk. So how should we balance the advantage versus disadvantage of using these drugs?
Important comments. Actually, when we prescribe specific drugs, we are concerned about the potential side effects in these specific individuals. So is that possible we prescribe the drug according to their underlying disease? For example, if the patient were actually infected with the high risk with the comorbidities, for example, the cardiovascular disease in the future, probably in this time, the primary prescription with the aspirin is controversial. But if the patient were actually infected with the IM or with the AG, I think it will be given much support to prescribe the aspirin in these patients. And for another condition, if for the patient with only limited hyperlipidemias, probably in this situation, if the patient were actually infected with the IM, the statin's prescription will be more beneficial effect between the use of drugs and between the reduction of the stomach cancer.
One of the problems of this kind of study is so-called competitive risk. That is, patients taking aspirin may actually die of cardiovascular disease. That's the indication for their aspirin before they develop gastric cancer. So is it possible that the lower number of gastric cancer is because they do not live long enough? to develop gastric cancer?
Yeah, actually, I totally agree with Professor Song's very important comments. Actually, when I conducting this kind of the studies, especially in the patients infected with a high mortality due to other comorbidities, for example, we compare the NSAID user with the non-users. It is a comparative mortality risk. You should adjust this potential very important bias. Then you can make more competent observations to report.
Any further questions? If not, Professor Xu will present a certificate to you for, do you have a certificate? Oh, I'm sorry, we don't have a certificate for you. I don't know why. We'll present to you later on. Thank you very much.
And all the topic of the symposium or the H. pylori single topic is closed here, but we still have a more climax or the attractive top abstract presentation award. We invite Professor President Wu to give the award to discover the nominated and then award with our welcome appreciations.
We have select 5 abstract from the submitted abstract. This is top abstract award. The first is Dr. Liu Zhiming. The second is Dr. Chen Boyue. The third is Dr. Zheng Xiuqi. The fourth is Dr. Lai Liuping. The fifth is Liang Zhiming. Please, we have the
Where do we go? Lobby?
I think it's better for us to start from here.
Yeah. I go to the toilet first.
Okay, you can go to the toilet. We can wait for you. Yeah, you can go to the toilet.
Yes, to the hotel.